Good morning and welcome. I'm going to ask Senator Long to lead us in a Pledge of Allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
So I know that we have some hearings scheduled, but we also have some bills that we may be able to exec today. I would take a motion to go into executive session. Have a second?
Second.
All those in favor say aye.
Aye.
All right. We're in executive.
You know what we're gonna do?
Okay, so we've got a lot that we haven't exec yet. Some things I think probably warrant some discussion. Others we may be able to deal with today.
I don't know. He's checking to see if Kevin. We do a little work.
I think just for discussion, I know I don't want to, I just wanted to see where everyone, or some thoughts are on.
Oh.
545, financial eligibility for Medicare saving program. This was Senator Rosenwald's bill that she brought forward, and it removes the resource limit for Medicare savings program. And this is more for discussion. I think that, I'm not ready to vote on this today, but I just wanted to get some thoughts of the committee, where we're at, what it does, and if there's any questions of the committee at this point that we may want or need to get answered before we do exec it. 545.
Did we get a?
There is a hearing report on that.
Yeah, and there, we did get the, this one.
Yeah. Recall this, we had a similar bill last year from Senator Rosenwald, and it was at a $14 million price tag. She has changed it a little bit. We're at 2.3 to 3.6 million. Obviously, we're the policy committee, not the, if we did ever do anything with this, it would go to finance.
So I don't see how we can. Senator Rushford, if I may, so, skipping to the last chapter, there's, a discussion that needs to be had about the fiscal note, and I'm hoping that we can get Senator Rosenwald in for part of that discussion, but I do think that there, from a policy perspective, is a benefit to how this would allow for, as we heard in the testimony, people are more senior community to be able to stay, be independent for a longer period of time. And I think that there's a savings on the other side of it that needs to be considered if they're not, they're not in a nursing home, they're not in a county home, they're not in a place where there are other types of dollars that are ultimately come down to some public funds that are going there. That's one of the long-term benefits I see of a policy like this. So I wanted to add that, and thank you.
And I think I've shared one of my concerns with you, Senator, is that, policy-wise, I think it's something that I could get behind, but price-wise is the concern.
Yeah.
And, I know that even last year where we were in the budget year, we couldn't find a place for this. And again, the policy I can get behind. What I don't want to do is, and again, this is for conversation only, what I don't want to do is put in something today that down the road we can't afford to do and then take it away. Is that I think we'd be in a much worse situation if we did that. And that's just my initial thoughts.
No, and so may I?
Yeah.
So I think that if it's a good policy and it can make could come out of committee to be discussed by our colleagues as good policy, but then our colleagues in the finance committee who manage the funding side of the house, they have the opportunity to look at this. It doesn't make the commitment that this is what we'll end up doing. And there may also, sometimes solutions start to evolve when you have a little bit of room. And by putting this into finance for consideration, we may give this a little more, what do I say, resuscitate or breathing room to this, give it a few more breaths and compressions.
Sure.
Ultimately, we'll vote, if not today, another day, and we might not vote the same way, but I do understand what you're saying, and I respect that, so.
Sure. Any other comments or thoughts on 545? All right, we'll bring that up another time. I just wanted to bring it in front of the committee and get thoughts on that. Just to check in, Senator Prentice, I know you're working on something with Senate Bill 480 for prior authorizations for physical therapy. Any update on that?
Thank you, Senator Rochford. No update except for that I've connected with Paula Rogers from AHIP, and I'm trying, hopefully we can get a Zoom on Monday between AHIP, Cigna, Anthem, Harvard Pilgrim, the OTs and the PTs, so that by the time we meet, we're going to meet next week.
Yes.
Hopefully we'll be in a place then to talk about what our solution is.
Very good.
So the goal is not Friday. Friday's going to be tight. I'm hoping for Monday.
All right.
Put a placeholder on your calendar, Peter Bragdon. All right. That's right, Captain. So yes.
All right.
Progress.
Very good. Thank you. The other one that I wanted to bring up, and you have a amendment in front of you on Senate Bill 457. Senator Reardon.
Oh, yeah, where did I put that?
This is relative to licensing of physicians who graduated from medical schools outside the United States or Canada. I think during the hearing, we brought up, there was some questions that there may be some problematic issues with some of the wording that was in the original bill. I asked her to work on that. She has submitted an amendment.
0477S.
0477S. I think
Are we
the
in a place
amendment,
to move the amendment and then move the bill, you think?
move the bill and then the amendment.
Or the bill and the amendment, but this meets the this is what some of the stakeholders are concerned about.
Yes.
And has come to a good place on this, so
Yep.
So I'll move SB 457 ought to pass.
I'll second that,
And I'll move amendment 2026-0477S.
and I'll second that.
Any further discussions on the amendment?
Appreciate the work of the stakeholders.
So all those in favor say aye.
Aye.
Any opposed? So ought to pass as amendment. As amended, all those in favor say aye.
Aye.
Any opposition? I'll move consent.
Second.
All those in favor say aye.
I,
So it's on consent. I will take that one out. I'm a co-sponsor of that one. All right.
Chair Rushford, if you have, I know we're tight on the schedule, but I see Senator Rosenwald here. She just missed the discussion we were having on 545. I didn't know if you had any questions for her.
So 545, Senator, we were just talking about the, I think there's some, we understand that this is something that's very similar to what you brought forward last year. Much reduced in price from what it was last year. I think we're going to continue to discuss this. We're not ready to take action on it, but we'll be continuing to work through it. I think, one of the concerns that, I had voiced was, policy wise, I understand what you're trying to do. My concern is price. And we'll be talking amongst ourselves, as we move this along. We'll be, we're not taking any action on it today. We'll keep talking about it. Yeah.
Thank you very much. I appreciate the committee's thoughtful consideration of this bill that's important to low-income seniors. And there are two parts to it, obviously. One is the removal of the resource limit. But the second half of the bill is the commitment to continue doing, to clarify that we're going to continue doing what we've been doing all along statutorily, which is automatically enrolling people who are on these programs in the low-income drug subsidy that is paid for entirely with federal funds. And there was some confusion after the passage of the One Big Beautiful Bill, which had a sort of a pause date until 2034. But the department has said, we've been doing it all along. We don't have plans to stop, but it clarifies that. We don't yet have a good cost on the first part of the bill. And that's what finance would be looking at.
And the first part is,
The resource limit.
yeah, okay,
Thank you very much for letting me speak.
all right. Any questions for Senator Rosenwald? Oh, thank you very much. I know we've got, Senator Fenton has to get somewhere real shortly, but I wanted to bring up Senate Bill 441. This was just see where we're at on this. This was the MOU for transporting folks in between towns. I did ask Senator Sullivan to reach out and have a discussion with was it New Hampshire Legal Assistance?
Yep.
She did. They submitted recommendations for an amendment. That's the amendment that you have in front of you right now, which it essentially sets up a dispute resolution between two municipalities. If
Do we know if there's going to be a cost to this?
that's a good question.
Should we see, why don't we have a discussion with LBA and see if this is
Yep.
going to change the fiscal note on
I
it?
can do that.
Senator Rochford, if I
Yes.
may, I want to check, now we've got this amendment with the municipal association, because intergovernmental agreements, are already something that can be established for other services that get shared between, expectations and services shared between communities, not necessarily shared, but like what one's responsibilities are.
Sure.
And another, and I think that it may already allow for this, so I don't want to put something,
Okay.
we might not need to do this, is what I'm trying to say there. I think there's a mechanism, but I need to check with the municipal association. And as you can see, I have my to-do list right
Yep.
here.
If
so-
you can check with the municipal association, I'll check with LBA and
Got it.
we'll go back to that.
Send them a, because I think it's,
And just an update, I have been speaking with Senator Ricciardi on the risk pools for childcare. She's working on an amendment, that's Senate Bill 614. We may see that as soon as next week. And that's where we're at. I take a motion to come out of executive session.
seconded.
All those in favor say aye.
Aye.
Any opposed? All right, we're out of executive session. We are going to open the hearing on Senate Bill 544, limiting changes to prescription drug formularies under health benefit plans. And I'll call Senator Fenton.
All right, thank you, Mr. Chair and members of the committee. It's good to be here in HHS. I think this is my first and last time this year I'll be in here, so howdy. For the record, my name is Senator Donovan Fenton. I represent District 10, and I'm here to testify in support of Senate Bill 544. At its core, this bill is about fairness, predictability, and continuity of care for patients and families who rely on prescription medications. When someone enrolls in a health insurance plan, they do so based on the benefits promised at the start of the plan, including which prescription drugs are covered and at what cost. What this bill says is simple. If an insurer sells a plan with a certain formulary, they should not be able to fundamentally change that formulary mid-year in ways that can harm patients. This bill does not prevent insurers from managing costs. It does not prohibit formulary changes altogether. It simply requires that significant changes, such as removing a drug from coverage or shifting it to a higher cost tier, occur at plan renewal, when consumers actually have the ability to shop for a different plan if they choose. The real-world problem this bill addresses is not theoretical. It came directly from a New Hampshire family who contacted me after their insurer removed a medication their child had taken successfully for years in the middle of the plan year. Under current law, that family had no meaningful recourse. They could appeal, but even a successful appeal often results in much higher out-of-pocket costs. And critically, the loss of coverage for a prescription drug is not considered a qualifying life event, so families cannot change plans to protect themselves. This is not a functioning marketplace. This is a one-sided contract. I want to address the fiscal note directly because I know cost concerns are important to this committee. The insurance department notes that limiting mid-year formulary changes could increase carrier costs, and those costs may be passed on through premiums. And I want to acknowledge the concern honestly. However, it is important to put that into context. First, several states have enacted laws just like 544, including Texas, Louisiana, Nevada, and New Mexico, and they have done so for more than a decade in some cases. Texas has prohibited mid-year formulary changes since 2012, and guess what? The sky has not fallen in Texas, at least not that I know of. The states continue to have functioning insurance markets, insurer participation, and cost management tools while also providing stronger protections for patients. Second, 544 allows insurers to make formulary changes at renewal, apply those changes uniformly across identical plans, remove drugs that are deemed unsafe, encourage use of generic and lower cost alternatives. What this bill prevents is an arbitrary mid-year disruption that shifts financial and medical risk entirely onto patients who have no ability to respond. I don't know of another contract that you can change mid-year. Third, even the fiscal note acknowledges that increased premiums could result in increased insurance premium tax revenue to the state. There is no identified increase in state expenditures. Most importantly, we must weigh potential marginal costs that impact against the very real costs to families when stable treatment is interrupted, worsened health outcomes, emergency care, lost productivity, and financial hardship. Those costs do not disappear. They simply shifted onto patients, employees, and the healthcare system as a whole. 544 is about continuity of care. It is about ensuring that people who are doing everything right, working, paying their premiums, following their doctor's advice, are not blindsided halfway through the year by changes they could not anticipate or avoid. This is not a radical proposal. It is patient protection policy that is tested in other states, refined over time, and shown to be workable alongside responsible cost management. You're going to hear a lot of scare tactics today, and I just want you to remember that other states have passed this, and they are doing just fine. I respectfully ask the committee to support 544 and give New Hampshire patients the stability and fairness they deserve. And I'm happy to answer any questions you may have.
Great, thank you. Are there any questions for the senator? Just had a quick question for Texas. As far as renewals go in Texas, is it similar to New Hampshire where it could be any month, or do Texas renew their plans? Do we know that?
You know, I don't know that answer, but I'll get it for you.
All right,
Thank you, Mr. Chair.
all right, thank you.
I'm going to zip to my committee, so I apologize. I'm not sticking around.
You got it. Thank
Thank
you
you,
very
guys.
much. John Stewart.
Thank you. My name is John Stewart from Keene. I'm here to testify in support of Senate Bill 544. I am actually the one that actually contacted Senator Fenton and asked him to sponsor this bill. Last year, out of the blue, someone very special to me received a letter from their insurance company saying they were no longer going to cover their medication. This medication was very important to this person. It has helped them overcome a serious medical issue. And the letter says you have 60 days to decide what you want to do, but we're no longer covering this medication. To watch that person start to cry and say, what's going to happen to me now, is heart-wrenching. And it shouldn't happen. As Senator Fenton testified, this is continuity of care. It's a care that was provided by their doctor. They had already gone through the trial and error period to receive the recommended dosage to make sure that everything was fine. One of the things that this person was told not to engage in is stress, and to have that letter come had them relive the entire episode that caused them to be on this medication. It's a sense of fairness. It's patient safety. To change a drug that they have absolutely no idea whether or not it's going to work or not, and go through that rough patch again is just unfair. It's a fairness. When I did the research on this topic, I found that this is a common practice, that insurance companies can change their formularies anytime they want. And all we're asking for this with this bill is that they can still make the decisions. They can still decide what drugs they want to cover. They just can't implement it until the next plan period. This gives the patient, their families, enough time to formulate a plan, meet with their doctors. To get a appointment with a specialist is extremely hard. You're probably not going to get everything covered within the 60 days before the medication ends. So you're kind of at wit's end to be like, well, I guess I have to do this. And as I was researching it, the more people that I spoke to that this has happened to, it's getting to the point where when are we finally going to say enough is enough and get back some of the protections that we should have as citizens of New Hampshire, and not let the insurance companies decide what's best for us, but let us and our doctors who know us personally decide what's best for us medically. And the one thing that I do want to say is that I hope there's no confusion. Senator Fenton briefly touched upon it, is we're not telling the insurance companies that they can never make these decisions. They can make those decisions. They have every right to make those decisions. We're only asking that those decisions are not implemented until the next plan period during open enrollment, when people can actually say, okay, this plan is not going to cover this medication. Maybe I want to switch to another plan and do what's best for them and their family. That's about it right now. I did provide you with written testimony that is much more thorough. And if you have any questions, I'd be happy to answer them.
Thank you very much. Are there any questions? Senator Bertzel?
Thank you, and thank you for taking my question. When your friend received the letter, did the insurance company recommend any other medications that might be available?
They did recommend other medications that they could take. The issue was we didn't know what those medications were. They didn't know what the medication were. In the very beginning, when this first happened, they had to do a trial and error period to find out the right dosage. So this was it's basically starting all over again. When you talk about re-victimizing a victim, this was re-victimizing a victim in the sense of a medical situation. But they did give us the medication that we could take. We had to do some research, but again, we're not professionals. And it's like giving us a name of something and, we don't know what it's going to do, what interactions they had or anything like that.
Yeah.
Just one last question. How long did it take her to get in to see the specialist to start working on the new medication?
It was probably close to a month because they were worried that the 60 days was going to lapse. And they gave us you could do an appeal period. And if you were successful in the appeal period, they would provide the medication, but this person had to pay for full cost. So it's really not an appeal where you actually win. It's more of another stab.
So in that 60-day period when they were trying to do that, the insurance company required them to pay the full cost of this?
If after they canceled the medication, if they won the appeal, the insurance company would still provide the medication, but they wouldn't pay their cost for it.
Thank you.
I've got a quick question on the same lines, and I'll let you, Senator Long. So did you, and I was writing when you were talking, so I may have missed that. Did you pursue the appeal period or the appeal process?
No, I've been through the appeal process before myself. It's a long arbitratious appeals process where it's back and forth. And their concern was more, let's get this fixed before the 60 days ends as quickly as we can, instead of waiting for the appeals process to occur and then go forward with meeting with the doctor and getting the right prescription for them so that their continuity of care is going to continue.
And I agree with you. Sometimes that can be a long process, but sometimes it's a matter of picking up the phone and explaining the situation.
They said that there's a 72-hour window. Sometimes it's less than 24 hours. And based on my experience, it's deny at the beginning. And then if you continue to push it, they may approve it. But the caveat was they can approve it, they'll give you the medication, but you're paying for it.
I mean, I'm a pharmacist and I've been in this situation, and sometimes that happens, yes.
Yeah.
But other times it's a 5-minute phone call, they approve it, they do a prior authorization, and New Hampshire has taken a lot of steps over the last several years to improve that process. And I've been on the receiving end of what you're describing. So I just want to see if the process, if there's something we can streamline in the current laws that we have that would make your situation a little bit better. And this information is helpful to
I
get to
think,
that.
I don't know if there's a way to streamline the process that's already in place. I think it needs to be revamped and just made so that the average everyday person can understand it's not going to change until the next enrollment period. And as Senator Fenton touched upon, the sense of fairness. They can change it all the time. They've done it multiple times during the year, during my research. And the patient or the enrollee has absolutely no say in whether or not they can change their plan. For example, you choose the highest tier plan, the most expensive plan, because the medication is covered. They get rid of the medication. We can't change to a lower plan and save ourselves some money. We are stuck with that plan until the next enrollment period. So this is really a sense of fairness to balance the scale, and it's beneficial to both people. You know, I've read and done research where the insurance companies said that they're able to save money. And I'm like, great, but my plan rates don't change in the middle of the year when they save money. The cost isn't placed back onto me where I saved money. It's more of a, hey, thanks, we saved money, our revenues went up. Or the pharmacy benefit managers got a little bonus with a rebate or a special fee or anything like that. But it just really comes down to a sense of fairness and stability. When we go through the enrollment period, we're looking at everything to understand what we're going to have to pay every month, and we're going to know that we're going to be following the plans that our doctors prescribed with the medication. And no one really wants to take medications. Sometimes it's a necessity. And it's that financial stability, it's the mental stability, just to understand that, hey, everything's going to work out for this year. I picked this plan, and then all of a sudden in the middle of the plan year, it's just this, you know, red flag that pops up. And now the whole stability part is gone.
Sure. Thank you. Senator Long had a question.
Thank you, Mr. Chairman. Thank you for your testimony. Very helpful. How close were you to refilling the prescription when you received a notice that it would not be covered?
It was 6 months.
6 months prior to
It was six, it
refilling?
was in, well, yeah,
Okay.
6 months.
Very good. Thank you.
Any other questions for Mr. Stewart? No, thank you for coming in today.
All right, thank you.
Holly Stevens.
Chairman, Chairman and members of the committee, my name is Holly Stevens. I'm the Director of Public Policy at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a grassroots nonprofit organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. I am here today in support of Senate Bill 544. Finding the right medication for somebody who has a mental illness can be a very long process of trying out different medications, trying out different dosages. However, if the doctor is able to find the correct medication, people are able to live very productive, successful lives. Different medications, psychiatric medications, are not interchangeable, even among the classes. They have different mechanisms of action in the way that they work in the brain. And so switching one medication out with another is not always a possibility. And finding a new medication for somebody can take a very long time. We're talking, 6 months to a year sometimes to find the correct medication. Individuals with mental health conditions who are unable to access the most appropriate clinically indicated psychiatric medications can experience homelessness, having to go to the emergency room and be hospitalized again, and or being incarcerated. And I referenced some studies for you in my written testimony about the percentage increase of folks when they're not on the correct medications that this happens to. And we know that that these findings highlight why people with mental illness need continued access to the medications that work for them. And as you heard, many individuals, when they're picking their plans during open enrollment, one of the things they look at is the formulary. Employers also look at those formularies when they're choosing plans for their employees. And so if they change, they're allowed to change the medications anytime throughout the year. People with mental health conditions end up having to go through this process all over again. By the time they get stabilized on that medication, there might be a new plan year that rolls around, and again, they're stuck in that process. I did identify one small issue in the bill that I did talk with Senator Fenton about, with the word modification in there. I'm not sure if that would disallow additions to the formulary. And that would be concerning if a plan was not able to add drugs to the formulary during the year if a new drug came out onto the market. So we would suggest looking at maybe using removal instead of modification. But also with that in mind, if removal was used, we would also suggest language that would prohibit the insurers from moving the medications to higher cost tiers during the plan year, because that was a issue that was brought up by both Senator Fenton and Mr. Stewart, that insurers can just move a medication to the highest cost tier, which makes it financially prohibitive from somebody being able to stay on their medication. When they signed up for the plan, it was on tier 1, now it's on tier 4, and they just can't afford it any longer. So with those changes in mind, we do support this bill, and I'm happy to answer any questions that you may have.
All right, think of any questions? Senator Birdsall.
Can you just go through the modification piece? What did you want it to change to?
Instead of saying modify or modification, using remove and removal. And again, I've talked with Senator Fenton and I asked him, does this mean they would not be able to add a medication? He was still looking into that. So if it's not an issue, great, we don't have to deal with it, but he is looking into that, and I'm happy to work with him and the committee on that. Thank you.
Any other questions? Thank you very much.
Thank you.
Sabrina Dunlap.
Good morning, Chair Rochfort and members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations at Anthem Blue Cross Blue Shield. Thank you for the opportunity to testify. We are opposed to SB 544, but if the committee does move forward with the bill, we would definitely welcome the opportunity to work with the sponsors and stakeholders on ways we think the language could be improved. Excuse me. So this bill would significantly limit our ability to manage our formulary and make timely changes for the benefit of our members. When we make changes like moving a drug or moving it down on the formulary, members and their providers can request exceptions. Also, for members on a drug and it's going to be removed at the beginning of a plan year, we often grandfather those members in, so there's no disruption for them. So we really need the flexibility to make mid-year changes to manage safety and cost concerns. If there are new safety or efficacy concerns, or if a clinically superior drug is available, we might make changes to account for that. And prohibiting mid-year changes will lead to significant waste in the system, especially when less expensive but therapeutically equivalent drugs become available. So, one of the things we try to do is promote less costly biosimilars. I know the state has taken some policy actions on that very front to try to lower drug costs, which is one of the biggest drivers of healthcare costs in the state. And we cannot help members move to lower cost but just as effective biosimilars in states that limit our ability to make changes to the formulary. So, ultimately bills like this are a way for drug companies to ensure that higher cost drugs stay on formularies, and this does drive up costs for everyone. Our calculation is that this bill would lead to a $10 per member per month increase, which is very significant. It's one of the highest I've seen of any bills in the legislature. That's more than $100 per year for each member. Just for Anthem members in the fully insured market, that would be more than $15 million added to their costs every year. That's just more pressure on the fully insured market and more costs for employers. So I'm happy to take any questions. Thank you for the opportunity to testify. I do have a couple of small things about the bill language. One would be the effective date, which is 60 days after passage, but obviously have some bigger concerns than just that. So thank you.
So I've got a few questions before I open it up to the committee. So when there is a change, you said that there are opportunities where you change your formulary to less expensive therapeutically equivalent drugs. When that happens, do the premiums lower to reflect the savings?
Thank you for the question. I would have to verify, but we can't make mid-year changes to benefit
Okay.
to the costs, I don't believe. I can double check that.
All right.
But certainly longer term, the idea is to lower the cost so that people have lower premiums in the next plan year.
Okay, thank you. I've got a couple others here as well. So when someone is contracting and purchasing a plan, are they notified at the time of purchase that the drug formulary may change mid-year?
Thank you for the question. Yeah, I will verify, but it is spelled out. I believe it is spelled out for members, and then they also do get at least 60 days of notice. I think under state law, we're required to give 45 days notice, and we actually only make changes at the beginning of the year and one time mid-year.
Okay.
But yes, that is spelled out in the contract.
More questions. We're getting there. So drug contracting is, I mean, I understand, your plan will negotiate prices on drugs. And I think probably the problem that I'm seeing here, the reason why we're here today is those contract negotiations don't necessarily line up with plan dates of contracting. So, we're not or asynchronous here, and that's why we're in this trouble.
Yes, I agree with that. I think that is correct.
Okay, and last question. So you talked about when there are changes in the plan, there are, I think you said many times, these changes are grandfathered. Do you, maybe you don't have an understanding of this and it's okay to get back to me. So let's say it changes. What's the prior approval process for Anthem to appeal that change? And whether it's flat out grandfathered or how difficult is the process to appeal a change to ensure that there is a continuity of care?
Mm-hmm. Yes, thank you for that question. I can definitely get back to you with details, but my understanding is certainly if somebody needed to be on a brand name high-cost specialty drug, for example, there is a process for them or their provider or both to say, we need to stay on this drug. And my understanding is generally that would be granted. And then, like I said, I think it is sort of a general policy that if there's going to be a change at the beginning of the plan year, oftentimes people who are already on the drug can stay on the drug.
Great.
But I can find out more about
All
the
right.
actual process for you.
Thank you very much. Are there any questions from the committee? Senator Prentice.
Thank you, Chair Rochefort, and thank you, Sabrina, for taking my question. I think you guys might have gotten close to this, but talking about when there is a change made and there is an appeal. So two parts to this. One, who processes the appeal? Is it like a medical director that, reviews this and makes the medical decision on whether this, changing drugs would still meet the basic, meet the therapeutic needs of that patient? Like, who makes that decision?
Thank you for the question. I will get back to you. I don't want to misspeak on that. I believe it probably would be our medical director who looks at that.
That's great. And one quick
Absolutely.
follow-up. And do you know what the percentage is, or how many appeals actually happen and how many are ultimately granted?
That is a great question. I don't know the answer. I'll definitely get back to you on that as well. Obviously, we do not want disruption for our members.
Yeah.
So I think most of the time we're talking about changes where there's a biosimilar that's a lower cost that's just as effective. But I will get back to you on sort of the number of times people seek to appeal changes.
Yeah, I would be interested in that as well. So if you
Okay.
could send it to the whole committee, that would be great.
Okay, I can definitely do that. Thank you.
Any other questions? Senator Birdsall.
So, listening to one of the previous individuals who testified, even though their medication had been modified and they were notified that it was modified, they are not allowed to change their plan to choose another plan that will cover it. Why is that? Because if they're locked in for a year, shouldn't the medication be locked in for a year?
Thank you for the question. I think the insurance department could probably speak to this too. My understanding is, we don't make the rules around when members can make changes about plans. Certainly under the ACA, we are bound by federal law on that. So we don't make the rules about open enrollment and when people can choose new plans. And so I don't know, I don't have a great answer for that, but.
Yeah.
So I know that from my experience working at Raytheon, if you have a life-changing, like a child's born, marriage, you're allowed to change your policy. Is that federal law?
Thank you. I don't want to misspeak on this, so I will look into that, or perhaps the insurance department can answer it more clearly. But I know under the ACA, we don't make the rules, but I have to double check on other types of plans. So sorry, I don't have that off the top of my head.
Any other questions? Thank you very much.
Thank you.
Paula Rogers.
Good morning,
Good
Mr.
morning.
Chair, members of the Health and Human Services Committee. Thank you for the opportunity to speak. I've been listening to the testimony, and I'm providing you the provision of law that would be amended if the bill were to be passed, because there is laid out in that provision a standard for the exception process, which is available to a member who finds him or herself in a situation where a drug that they've been utilizing within the last 12 months is somehow no longer available. And the question becomes, when you see a member in that situation, you would want to provide notice. And that's why the provision before you has a notice period. I think you're going to be looking basically at paragraphs Roman 1, 2, and 3, where the process is laid out rather clearly, but it's sort of submerged in a very lengthy section of law, which goes on and on electronic filing for prescription claims and all sorts of things if you kept reading. But the essence of what this bill is addressing is in those first 3 paragraphs, and maybe into paragraph 4, which is information that carriers are supposed to keep. So as I understand it, this carrier is deciding, or PBM is deciding, this drug is coming off the formulary. And the person that signed on is 6 months into the coverage. The obligation of the carrier is to give a 45-day notice, i.e. notice is received and there's a 45-day period during which the drug will continue to be covered. If the exception process is utilized, and I think I was listening to Mr. Stewart's testimony with great interest, and I hope I can chat with him after the hearing. If that is, you would look at Roman 2. So it talks to an expeditious exception process, not to exceed 48 hours, i.e. Exception is received, notice of exception is received. The reply has to be provided within 48 hours. Where I'm beginning to sort of lose track a little bit is after that period of time, say the answer is yes, we'll give you an exception, that person will be carried along on that medication through that policy year. If the answer is no, is there a higher appeal? And I assume there is, but in reading this, it's kind of complicated. So I can't answer that question. But somebody would certainly like an opportunity for further appeal, and I'm guessing that it's available, but I don't know that for certain as I sit here. So I guess what I'm feeling about this is there are obviously perhaps some gaps in the person who receives the notice knowing what their opportunities are and whether they're accessing them properly. So if you have questions, of course, I'll answer them, but I need to find out what the opportunity is once the exception process is denied, i.e. no, we're not. Because if you go on to paragraph 2, it talks about prior authorization, which is a different concept. The exception process is kind of more expedient and immediate. But I assume that this is implying there is also an opportunity to appeal. I don't know that. So you can ask me the question and I'll have to say I don't know. But what I do know is that I think there needs to be some clarification on what happens after that exception process is activated.
Thank you very much. I know you've said it 3 times, but if I'm getting this correctly, we may be able to solve the problem here with just clarifying this paragraph, Roman numeral 2.
Well, I'm hoping, because you've heard from the plans, they obviously feel the value, not only for their patients, but also for the healthcare dollar that goes with being able to respond mid-12-month period for issues that may be more advantageous or to avoid issues that are becoming disadvantageous. And it occurs to me the extraordinary amount of drugs. I mean, New Zealand and the US are the only 2 countries that I know in the countries that we might compare ourselves to who allow for drug advertising. And all of a sudden, within the last 6 weeks, like everybody else, I watch sports things, I watch cable news, there are all these new drugs coming to the fore which have these strange names. I mean, Skyrizi I know about, but there are new ones that I've never heard of. And there seems to be the opening of a door of an enormous smattering of new drugs. And I don't know whether that's because the federal system is lightened up a bit. I have no idea. All I know is that there's a tremendous amount of money coming into that marketing theater. And the PBMs and the plans are obviously struggling, and I'm sure providers are struggling with somebody who comes into their office and says, you know, I saw that ad for psoriatic arthritis drug, and I'm on the wrong one. I need a different one because that ad, so there's a lot going on. And so any stability that can be provided at the same time, which opens up appropriately a clear consumer alley to get the relief they need, is what we'd be trying to seek here. And so.
MIBs and MABs. That's all those drugs are MIBs and MABs, all the new drugs. But Senator Birdsall has a question.
Thank you, and thank you for taking my question. So seeing all of this here in the RSA, obviously the patient is not aware of all of this. Would it be beneficial for when an insurance company sends out a letter stating that their coverage is not, their medication is not going to be covered, that a flow chart of some sort or direction on how to request an exception, so they know exactly what's going to happen, how long it's going to take?
I read this last night because I thought, where does this bill fit in? And it sort of refreshed my recollection. If you look at the end of the handout I gave you, you can see the source and what's been going on in this particular provision for 21 years. And I didn't go back and look at it all. So I suspect that things have come to the fore and committees like your own are doing just what you're doing. Is there some way we can clarify this? And Senator Birdsall, you bring up a good point, but I think I remember something in here that suggested that there had to be some clear notification of what the exception process was. And the question, I'll again, when I sit down and don't take up all your time sort of wandering about here, I think we need to make sure that that has been locked down. And it may be in regulation as well. So for every statutory provision, there are also managed care regulations in this section.
Thank you.
Any other questions? No, thank you
Thank
very
you.
much. Cam Lapine, you're up.
Good morning, Mr. Chairman, members of the committee. For the record, I am Cam Lapine. I work at Orin Reno. I'm here today representing Cigna. I'm going to defer to my written testimony on the contents of the bill. I'm just going to answer Senator Birchel's question that she asked Sabrina. I did some research on my phone back there. The two questions about why there's only once a year you can enroll in health insurance and what determines what a qualifying life event, those are both in the ACA. And I can't explain why because I was in middle school when the ACA was passed. But I'm happy to take any other questions you may have for me.
Are there any questions for Cam? No, thank you. We have your testimony. Thank you very much. Peter Bragdon.
Thank you, Mr. Chairman, members of the committee. For the record again, Peter Bragdon, with representing Harvard Pilgrim Healthcare, the state's not-for-profit health insurance carrier, here today to express concerns about this bill. I think others have already covered some of the reasons why formularies may need to change and the things that go into that. I'd like to provide some context, I guess, from the perspective of a small regional nonprofit health insurance company. We are not one of the behemoths. We do not own our own PBMs. And so there's operational things here that would affect all carriers, but certainly affect us. And I think Senator Rochefort kind of hinted toward this early in the testimony from others, is that this might be one situation if every single health plan in the state started on January 1st and ended on December 31st. But we, the other carriers, have hundreds of companies that purchase plans from us, and they all start at different times, different months they start at. So right now we have, I think, maybe 3 different formularies that people can choose from, depending on the, the level of cost and service. We would essentially have to create 3 separate formularies, basically for every 12-month period. So we would have to manage 36 different formularies in order to comply with this, because it says the changes can only be made at the start of a plan year. So if we make changes for the January plan, they can affect the February, March, April, May, June through December plan. So we'd have to basically maintain 36 different formularies. That would be obviously very expensive and difficult to implement. And that goes back to the whole discussion of the cost. The cost will definitely increases the cost, as you've heard me say before, get pushed down to premiums and affects the client. I think Senator Rochefort asked is, do the premiums go down if changes are made in the formulary? Obviously the premiums per year stay stable, but what happens at the end of the year, you have to predict what you're going to do for the following year. And so that's based on what the estimate of the claims cost are going to be, how much money you have in reserves, and then the premiums have to make up that difference. So if money is saved, then you have more money in reserves and there's less pressure on the premiums. If there's less money in reserves, then it has to come, again, the insurance fairy isn't going to show up. It has to come from premiums. And when premiums go up, people reduce their coverage and don't get the care they need. So it's a balancing act. I do think the current statute tries to balance that, and Paula had passed out the current statute, and Roman numeral 3 in that statute covers the notification. So, and I will say this, this particular statute is a little Byzantine. It started in 1999 and it's been adjusted every few years since then. So it's pretty much a mess. But Roman 3 talks about the notice that has to be given to people when a drug is dropped from the formulary, and talks about having to let them know what the exception process is. And then I think Roman numeral 2 talks about the actual exception process. So there's perhaps changes that can be made to help clarify the statute or make it clearer for the customer. But those are my comments on it. I think the biggest thing on us is the impact operationally to maintain 36 separate formularies. Thank you.
Thank you. Any questions? I just want to jump onto something. Spread pricing.
I didn't say anything about.
We've talked about that a lot this year. And for the first time, I can see in a case like this, where a company like yours, that may protect you, spread pricing, where there's formulary changes, contract changes. I can't believe I'm saying this out loud, but
I like
here
what
I
I'm
am.
hearing.
But, as I would understand, just based on what your testimony, that spread pricing may mitigate some of these rapid swings up and down for a carrier like you. Who
For a
does not
carrier
own
like us, without our own
own a
PBM, it just transfers that risk. And when there's more risk, then the prices have to increase to cover that risk. So that's, yes.
Can't believe I said that
I
out
can't believe
loud.
that, but I'm very happy.
Yeah. Are there any questions, any further questions? Thank you very much.
Thank you.
That's the end of our list. Is there anyone else that would like to speak on Senate Bill 544? With that, I'm going to close the hearing. I'm going to open the hearing on, I think we're on 549. Yeah, Senate Bill 549, prohibiting the state or local government from distributing or funding organizations that distribute drug paraphernalia. I'm going to open the hearing and ask Senator Murphy to introduce his bill.
Good morning, Mr. Chairman, members of the committee. My name is Senator Keith Murphy. I represent the people of District 16, North Manchester, Goffstown, Raymond, Hooksett, and Candia. So I live in North Manchester, Mr. Chairman. I'm glad to see another Manchester senator in the room on the panel, Senator Long. So for those of us that live in Manchester, we have been plagued the last few years with the daily sight and dangers posed by drug needles left everywhere. And when I say everywhere, I mean everywhere. Sidewalks, playgrounds, gutters, doorways, cars. So just a couple of examples. This is a picture that I took. It's coming around if you don't have it yet. I took this picture on a playground at Livingston Park in North Manchester. Now that's actually my son's bike. He was sitting right next to it, and I said, stop right there before you get off your bike. The next page, there's two pictures here. The one on the left was sent to me by a constituent. Her 8-year-old daughter found this behind her house. And it's a box filled with what appears to be about a dozen needles. The picture to the right, I took. That was taken in October. It's a picture of about 15 needles, a strap, and if you look really closely, you can see a spoon that was used for cooking the drugs. This was found on Elm Street in a doorway, the stairway leading to a doorway on a business. So just two more examples. I had a constituent call me back in October when I said I was going to file this bill. And she told me she'd come out the previous day, just the prior day, and found a half dozen needles in her car because she left her car unlocked overnight and it was discovered and being used as a place to shoot up drugs. I got a call 2 weeks ago from a constituent. He owns a retail property. It's in between tenants on Elm Street in Manchester. And over a 10-day period when he didn't visit the property, people broke into his building, used it as a shoot-up gallery, basically set up camp there. He had to go in, bore up all his windows, all his doors, and he found thousands of needles, to the point he was sweeping up with a broom. This is beyond unsightly. It's a hazard. It's dangerous to the people in our community. And so when I saw this problem, I thought, where are all these needles coming from? Now, there are a number of organizations, nonprofits, that are paid with grant money from corporate donors and tax dollars to distribute these needles. And it's done so under the well-intended, but I think misguided motivation that handing out clean needles saves these addicts, these addicted people, from blood transmitted diseases. There's several organizations that do this, but I'm going to talk about one that's most active in Manchester. That's the New Hampshire Harm Reduction Coalition. Again, I do not doubt their motivation. I'm sure it's well intended. But I handed out a copy of a 2024 report. There's 2 pages I want to talk about real quick. One of them is this big red page, and handed out by itself. 428,000 syringes disposed of. But then here's a page from the 2023 report, 986,631 sterile syringes distributed. 986,631, that's 2,700 syringes a day. Every day, Christmas included, every single day, 2,700 a day, paid for with tax money, plus corporate donations. By the way, the last page on that thing that I handed out here was from their Instagram page. They distribute something called boofing kits. If you don't know what boofing is, consider yourself luckier than me. I won't get into details, but this is tax money. So look at the fiscal note. It's $1.7 million. It's being used for grants for these organizations, plus local dollars. The 2 final points I want to make here is that handing out drug paraphernalia is not drug treatment. It's enablement. It's enabling. If we take that 1.7 million and put it towards actual drug treatment, I believe that would be a fantastic use for that money. But leaving these needles laying around is not in anyone's best interest. Any good done by these programs is more than outweighed by the danger posed to our community. What happens when someone's kid at a playground steps on one of these? If they're dangerous to addicts, they're certainly dangerous to everyone else. And that's my comments. Thank you, Mr. Chairman.
Great, thank you. Are there any questions for Senator Murphy? Senator Prentice.
Thank you. Welcome, Senator Murphy. Good to see you.
Thank you, Senator.
I had a constituent question, and I think I know the answer, but I just want to be sure. This, in terms of drug paraphernalia, we're talking about needles and syringes. Okay, correct?
Yes.
Only. This has to do with Narcan, so I'll get there, but I want to, when I read this, I want to make sure that agencies that distribute Narcan, that Narcan is not considered paraphernalia.
No state funds may be used for or provided to organizations that distribute drug paraphernalia as defined in RSA 318B1, including needles and syringes. I do not believe Narcan would fall under RSA 318B1. If that did, I would certainly look for an amendment on that.
I mean, by plain definition, it doesn't, but I want to make sure crystal clear. So
I do not believe it applies.
thank you.
Thank you.
Thank you, Senator. Are there any other questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. I certainly would agree with you with the respect to the needles being found. Last year, the city of Manchester is now requiring to do a 1-for-1 needle. Before, you would just show up and they'd give you a bag of 50 needles. So I could throw 40 of them away and, keep 10. And where would I throw them? I throw them wherever I am, in the park, whatever home I broke into, sleeping in the alley. But my concern is with not giving out any needles. Why? It's bloodborne sicknesses. I know that has been successful. I don't know if that would be reversed. What's your opinion on that? Do you feel that there would be more HIV, AIDS?
So there's 2 questions here, Senator, and thank you for the question. The first question was about the 1-for-1.
Yeah.
I followed that in the news. You and I live in the same city, not far apart.
Yeah.
And I do not believe that there is actually a 1-for-1. I understand that's the policy desired by the city of Manchester and the Board of Mayor and Aldermen, that they've adopted that policy. But my understanding is that if an addict shows up at these drug needle distribution sites, they still get the needles. They say, I don't have one. They don't get turned away without a needle. Right. That's number one. Number two, to answer your question, I would hope there would not be more bloodborne diseases being shared by these needles without needles being handed out. Again, if it's dangerous if used needles are dangerous for other addicts to share, they're just as dangerous for children on our playgrounds and people walking our streets. If we're going to hand out needles under the assumption that that reduces drug-borne diseases, we might as well make sites available for them to use the needles. You might as well open up a storefront somewhere and say, here, shoot up in here, and that way you can clean up your mess afterwards. That would be safer than what's happening right now. I'm not encouraging that policy. I don't believe that's a good use of tax dollars. But if we're going to enable drug use in the way that we are, we should just go all the way and open up a drug site, because that would be less harmful to our communities than what's currently happening.
Very good. Thank you.
Any other questions? Senator Prentice?
Oh, sorry, no.
Oh, no, all right. Thank you very much.
Thank you, Mr. Chairman.
Dr. Ballard and Jenny O'Higgins.
Good morning. Thank you, Chair and members of the committee, for the opportunity to provide some information on Senate Bill 549. For the record, I'm Jenny O'Higgins. I'm the Legislative Liaison for Behavioral Health at DHHS, and I'm here with my colleague.
I'm Jonathan Ballard. I work as the Chief Medical Officer for the Department of Health and Human Services.
So you've heard from the introduction of the bill that this bill would prohibit state and local governments from distributing drug paraphernalia, including needles and syringes, and as well as from funding as organizations that distribute such items. So the current law already prohibits any funding from being used to purchase syringes. Both federal and state funds are not available for the purchase. However, this bill would then extend that restriction so that organizations that distribute syringes couldn't receive funding regardless of whether or not the funds are for syringe purchases. So we just wanted to talk to you a little bit about the potential implications of that. So one of the way the bill is written, we'll start there, that just there is some confusion in how the bill is laid out. So on page 1, lines 2 through 4, there's a conflict with then lines 7 through 9. So there's both some legal and technical challenges there. The RSA 318B43, which authorizes SSPs to distribute sterile needles and syringes. And then in this version of the bill, there's a direct conflict that seeks to restrict funding for those activities that are already expressly permitted under the existing law. So between those lines 2 through 4, and then the lines 7 through 9 directly conflict with them. So that could be pretty confusing for interpretation. Additionally, in section 2, so that's lines 10 through 16, it specifically applies to the pharmacy statute. And so it's a bit confusing to us also where it would sit in the pharmacy statute and syringe services, then would this or would this not be able to be applicable to how we fund syringe services through DHHS. So those are, two confusing conflicts that the bill would be extremely hard to figure out how to implement, or maybe not be able to be implemented in the way that it was intended by how Senator Murphy just introduced it. If the bill were able to be carried forward in the way that it was intended, we do want to note some important fiscal implications and public health implications. So as you'll see in the fiscal note, we have current funding resources for syringe services programs, which include a federal grant of overdose data to action, as well as Governor's Commission funds and opioid abatement funds. It's important to note that both the Governor's Commission and the opioid abatement commissions are composed of multi-sector, organizations and representation, and their decisions are made based on expert opinions. And so those funds are being invested with a strategy to reduce overdose. And in New Hampshire, we've had the largest one-year decline decline of overdose fatalities in a decade in 2024. So we are actually seeing a really positive trend in overdose prevention. Nashua and Manchester calls for overdose have been the lowest that they've been in a decade. And New Hampshire has been outpacing all national declines. So we are moving in a really positive direction in this state in terms of overdose. And we have some concerns about how, while we're showing you an estimated expenditure reduction of potential $1.7 million, we actually believe that this would be an indeterminable fiscal note because it appears as a savings, but we believe that the cost would likely shift to emergency medical services, hospitalizations, an increased endocarditis, increased infectious disease, and uncompensated care at hospitals, which are significantly more expensive than prevention services. Additionally, in our interpretation of this bill, while we aren't sure that it can be implemented because of the technical concerns I already noted, if it were to be implemented, we believe that the way it is written, it would not just be organizations that are specifically doing syringe services, but rather all those that distribute syringes. And therefore, that could impact our recovery community organizations as well as our HIV programs. So over 400 people in New Hampshire that receive HIV case management and care through these organizations could also be directly impacted. There are significant public health consequences around the transmission of HIV and hepatitis C and other infectious diseases, as well as that potential increase in some of the other pieces that I mentioned earlier. So I do want to make sure that we also leave time in the speaking to make sure that Dr. Ballard can talk about some additional costs that we may see.
Sure. So presenting to you for information only today, and I was specifically asked to address in the fiscal note the question around costs may be shifted to hospitalizations and other medical services. So I looked for data that specifically would show us what would be the impacts to Medicaid and to state taxpayers if this bill were to be to pass. Even though the bill wouldn't do, from our legal analysis, what is intended, if the legislative intent were carried out, what I did was look at another state who actually directly looked at Medicaid costs. I've been in New Hampshire and worked as the chief medical officer and as the Medicaid medical director for the past 8 years. Previous to this, I worked in Kentucky as the state epidemiologist, and I was very surprised when I came across this journal article in the Journal of Rural Health that looked at Kentucky. Their Medicaid medical director that I worked with back then under Republican Governor Matt Bevin did a paper that looked at the syringe service programs. In that state, they have 120 counties, and their syringe service program law required that each locality, including both the town and the county, both approve and have oversight and interaction with the syringe service program. And so from 2016 to 2019, they had 66 counties and 80 sites that opened a syringe service program as operating. And those counties compared to the counties that did not operate that, adjusted for the incidence of injection drug use, saw about a 50% less cost in the Medicaid program directly for specific conditions that included HIV, hepatitis C, hepatitis B, infective endocarditis, abscesses, spinal abscesses. And so what I did then was to look at what is our cost in New Hampshire among the Medicaid recipients today. And if the legislative intent happened where we did not have the SSPs, the syringe service programs, what would be the cost to taxpayers? So we'll update the fiscal note, but I wanted to be very conservative in the estimate. So in one past year, fiscal year 2025, we had $8.8 million in claims for 744 people for these infectious disease medical expenses, an additional $8.1 million in HIV/AIDS cost for drugs, and $6.6 million in hepatitis C agents. So I don't believe that all of the costs would be reduced for the hepatitis C and hepatitis A medications, but for those specific costs associated with those infectious complications, those abscesses, infective endocarditis, which is very expensive per case, would be a significant savings. So if we applied the Kentucky data, it would be a cost of about $3.5 million increase for taxpayers in Medicaid. So I will update the Medicaid, I'll update the fiscal note to reflect that data.
So how we see this today in the fiscal note looks like short-term cost savings, but we do see really long-term public health and financial impacts. And also important to note, I know Senator Prentice asked a question earlier around naloxone, and I just wanted to quickly speak to that as well. The naloxone would not be considered drug paraphernalia, but there are a lot of additional pieces underneath the drug paraphernalia definition that does include drug testing. So kind of unclear what the implications would be on other organizations that maybe have the testing, as well as syringes and any of the pieces listed under drug paraphernalia, and whether or not that would impact their funding. Additionally, the robust naloxone distribution is really one of the major contributing factors to our overdose reduction numbers that I mentioned earlier. And our New Hampshire's SSPs are really have been attributed with saving hundreds of lives through their efforts to distribute naloxone. So outside of the syringe services, supports that they're offering, they are really the most critical partners in that distribution of that overdose reversal drug.
Thank you very much. We got some questions. Senator Birdsall.
Thank you. Thank you for taking my question. So, listening to the testimony before, I have major concerns about the number of syringes that are being handed out to these individuals, because they're not just putting them, they're putting other people in jeopardy. How many of the state, like Kentucky, you had brought up, Dr. Ballard, how many syringes were they handing out? Was it a one-on-one, or was it a box of 50?
Thank you, Senator Birdsall, for that question. So the beauty about that program, and if the committee would like, I'm happy to engage after this hearing on ways to improve the problem from Senator Murphy's very valid concerns. In that state, they require the locality, the town, and the county to both legislatively approve it, as well as the fire and police departments to be engaged and coordinate with them and to talk about, to address those concerns like that. Some of them put additional restrictions on per their local control, which includes the one-to-one distribution, such as in Manchester has done. So there are some ways, I believe, that we could improve the laws and work together to reduce the very valid concerns Senator Murphy has.
Additionally, we have any public health concerns, having syringes and that are in the community would be concerning. So we're weighing that as well as the risk of infectious disease spread and overdose fatality as well. But there are other strategies that may be more effective than effectively eliminating syringe services in New Hampshire. There could be additional disposal, and there could, making sure to not prohibit public disposal sites and other strategies like that, so that we can get needles disposed of appropriately to increase that public health piece. I think would be some of the ways that we could work together for a concern without, navigating into waters where we increase an additional concern elsewhere.
Yeah.
So, and I agree. However, when you have someone who, granted, she should have never left her car unlocked, but when you have someone who shoots up in the car at night, where is that individual who comes out to her car? What is she going to have to do? Is she going to have to call the police to have them, or the fire department have them? My concern is, yes, we can put this information out there and we can put these sites out there. But for the mother or the father that has their child in front of at the park, what are they supposed to do when they find them? So I think we need to really look at the program and see where we can refine it, not just put additional sites out to throw them, because obviously they're not doing that.
Mm-hmm. No, and I think it was just one of many potential suggestions. So to work through the issue that we are seeing, to make sure to address that. Thank you.
Jenny, if you could, you discussed there's conflicts in Senate lines 2 through 4, I think, and then other, can you just dive into that a little bit and show me where that is and explain that in a little more depth?
Absolutely. So I said page 1, but I mean, it is all
It's only
one
one page,
So I
yes.
think we're okay with that. So on lines 2 through 4, say nothing in this section shall be construed to prohibit the Department of Health and Human Services from administering and or distributing federal, and then that or other is being removed, funds to syringe services programs authorized under this section. But then when there's a section added, lines 7 through 9, that is in direct conflict, right? So it is saying that agencies are prohibited from doing the thing that is saying nothing in this section will prohibit.
Okay.
So, it seems conflicting. It's, at least confusing from a technical legal aspect that would need to be looked at. It's not.
The other issue that our attorneys flagged for us prior to this meeting was in section 2, when it references the pharmacy statutes. We understand that DHHS, the agencies that are involved with just funding syringe service programs, are not governed by those pharmacy statutes. So that's also seems to be a.
So it's 318, that's the pharmacy statute.
318, 43A.
We would need to put that somewhere else.
If the legislative intent was followed, this bill that section does not follow that.
All right.
Additionally, where it strikes or other on line 3, the opioid abatement and governor's commission funds both are sometimes considered other funds and or general funds, and so that's something to make sure that we look into, that both of those legislative bodies and multi-sector commissions have been making decisions with funding here in this space, and the removal of other funds may potentially impact them.
Great. Thank you very much. And Senator Birdsall has another question.
So I know you say it's in conflict, but because section 3 says, nothing in this section shall be construed to prohibit the Department of Health and Human Services from administering and dispersing federal, but agencies of the state, that is not, I don't read that as Department of Health and Human Services. I look at that as nonprofits distributing. And maybe just a definition of agencies might be something to put in there.
Yeah, I think it could use some work and cleanup so it's easier to understand and implement if as intended. But additionally, we did talk about the potential impacts.
Thank you. Are there any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. My understanding is there are 3 companies that are distributing needles in the city of Manchester. Is the New Hampshire Harm Reduction one of them?
New Hampshire Harm Reduction Coalition?
Yeah.
Yes.
They're distributing needles in the city of Manchester also?
That's my understanding. They're of the 3, it's called Queen City Exchange, but that's the name under the Harm Reduction Coalition.
Okay. And my understanding is that is federal pass-through state?
The funding sources are the Governor's Commission, the Overdose Data to Action, and the Abatement Commission. So those are the 3 funding sources that are currently going to syringe services in New Hampshire. I'd have to look at which of those funding sources are going directly to that organization for Manchester.
Okay, and one follow-up, if I may.
Yes.
With respect to the dispersing federal funds in agencies of the state, I think once the feds send the funds to the state, it becomes state funds that distribute to these organizations, correct?
We still consider them federal funds, even if they're running through our budget. So the Overdose Data to Action grant, that's federal funding. The other 2 sources, the Governor's Commission and the Opioid Abatement, are considered general or other funds.
Okay. Very good. Thank you.
Thank you.
Are there any further questions from the department, No, thank you very much.
Thank you.
All right, so we've heard from the prime sponsor, we've heard from the department. So we will be when we have a lot of speakers on a day like today, we will be limiting comments to 3 minutes. I'll ask Sophie to keep a time of that. And next one is, looks like Lauren Byrne, HIV Resource Center. You turn your microphone on, please. That gray button right there. Yep.
Sorry, I'm not used to this. I'm with the HIV HCV Resource Center in Lebanon, and we serve people across Grafton and Sullivan counties. Thanks for hearing my testimony. I strongly oppose this bill. The bill is framed as a bill about drug paraphernalia, but in reality, it would defund essential evidence-based public health services. At my agency, it would defund our whole case management program, where we work with 53 low-income people living with HIV, helping to maintain access to medications and stable housing. It would also defund our hepatitis C and HIV testing program. Last year, we tested over 300 people. It would also defund our overdose prevention education and naloxone distribution program. Last year, we distributed over 4,000 doses of naloxone. Our combined programs are a key reason fatal overdose rates are declining in New Hampshire. These are core public health interventions. They prevent overdose deaths and reduce the spread of infectious disease. Through our harm reduction program, we maintain contact, non-judgmental, consistent contact with our clients. This creates pathways to treatment and recovery and keeps people alive. When programs like ours are defunded, those pathways disappear. We connect people to medical care, housing, mental health services, substance use treatment, and other social services, often through warm handoffs that reduce barriers to care. This work helps identify health issues early and prevents costly emergency room visits. Harm reduction is not an abstract concept. It's a proven system of care for people otherwise disconnected from the healthcare system. If this bill passes, there will be more overdoses and preventable deaths, higher rates of infectious disease, higher healthcare costs, and the loss of trusted relationships with vulnerable community members. I urge the committee to reject the bill and support evidence-based public health strategies. And I would welcome any opportunity to meet with anyone to discuss our programs and how we work to protect our communities. I also wanted to speak very briefly about needle disposal, because I know that's a big issue, and I understand the concerns of the senator who spoke. We also have needles on the street sometimes, and we're instituting kiosks in the Hartford area right now where we can, people can dispose their needles. There's just a few boxes so far. I know Barry, Vermont had a pilot program where they put needle disposal boxes around, and that significantly reduced the likelihood that people would throw them on the street. We have a lot of people experiencing homelessness and they get displaced. And I think sometimes, I'm not making excuses for them, but I think sometimes needles appear where they shouldn't, and we understand that it's a concern. Whoops. Okay. Anyway, that's it.
Thank you. Are there any questions? No, thank you very much.
Yeah.
John Burns.
Good morning, and thank you for the opportunity to speak to you today. My name is John Burns. I'm the Executive Director of SOS Recovery Community Organization. We have 3 centers in Dover, Rochester, and Exeter, New Hampshire, as well as an award-winning community diner in Somersworth that hires and trains people for workforce development in the hospitality industry. That's a social enterprise project. I'm here in strong opposition to SB 549. All 3 of our centers serve as both recovery community organizations and recovery community centers, as well as syringe service and harm reduction programs. It's important to note that we also run juvenile diversion in Carroll County. We run adolescent programs. We run family support programs. We run a statewide criminal justice program for reentry and for people in probation and parole. We will have, this bill would would put us at a crossroads of either sunsetting all of our harm reduction programs or losing somewhere in the vicinity of 60% of our funding, which represents about $1.2 million for all of those other programs, because most of it is state or other funding. And so the ramifications of this are severe. I think it's also important to note that while we do syringe service is much more than just handing out syringes. I could train just about anybody to hand out syringes, but it's the connection that people receive when we hand those out, and most of those people are disconnected from every other program in the society. Our connection to those people through harm reduction helped facilitate the distribution of 3,476 doses of Narcan or naloxone in 2025 to the 3 communities we serve. More than 50% of that naloxone is not the state funded nasal naloxone. We purchase injectable, what's called intramuscular naloxone, as well as the syringes to administer that, because many of the people in the community would rather use that than the nasal. The state won't pay the $3 it costs us for the doses because it's administered through a syringe, so we get that through foundation funding. And so that is funded primarily by us. That part of the naloxone distribution would have to go away. Those were distributed to an estimated 1,347 unduplicated participants in our program in calendar year 2025. Those participants reported reversing 417 overdoses in our community. We are well aware that overdose deaths are dropping in our communities. We've done a lot of work. This is the type of work that's a direct result of those drops in overdose deaths, and that this bill is just misplaced. Public health experts have long attributed naloxone as one of the most important reasons for dropping overdose deaths. And I understand that some of the co-sponsors see syringe services and distribution to the community as enabling. I also understand that if you're on this committee, that I would assume that public health is a concern for you. And I'd like to believe that peer-reviewed science and research informs how we protect the
I'm
public
going to
health.
ask you to wrap it up. The time's up. But if you want to have a closing sentence, I'll
I
let you
do. I
that.
just, when we look at the improper disposal of syringes, I think we have to look at the fact that the research shows that when we have syringe service programs, there's less improperly discarded syringes. People are still going to use syringes. They'll drive to Massachusetts. They'll drive out of state to get them. They'll still be improperly disposed. There'll be nobody to collect them. And so there's other strategies that can be used, like community syringe boxes and things of that nature. And I also think some of the data that was presented by the sponsor was not accurate. It was looking at all of the syringes distributed by New Hampshire Harm Reduction Coalition without looking at the subcontracts, and the collection was the number based on just in Manchester versus their statewide. I'll let them speak to that, but I do think that those numbers were not correct, and we should be looking at the total statewide distribution and collection, because I believe most are 90%.
Any questions? Thank you very much.
Thank you.
Cheryl Pacapelli.
Hi, thank you. My name is Cheryl Pacapelli, and I appreciate you giving me a couple of minutes here to speak to the committee. So, I'm a person in long-term recovery for more than 36 years of continuous recovery, and I respectfully submit this testimony in strong opposition to Senate Bill 549. I offer my perspective grounded in both lived experience and decades of recovery advocacy. I've personally witnessed how people move from active substance use into long-term recovery, not in theory, but in real life. I have also seen the devastating consequences when public health systems withdraw life-saving supports. SB 549 would do exactly that. Harm reduction services, including syringe service programs, are evidence-based public health interventions. They reduce the transmission of HIV, hepatitis C, prevent fatal overdose, serve as critical points of engagement for individuals who are otherwise disconnected from our healthcare system.
So you've submitted this in writing?
Yeah,
Tell us in your own words.
I will tell you in my own words.
Thank you.
Like, I had a shortened version in my own words.
Yeah.
And I was
You let me know.
afraid
We
give
want to
you
hear
that.
from you. We can all read. We want to hear from you.
So people who don't have the ability to use these programs often do not survive. I have been to hundreds of funerals in the 36 years I've been in recovery. In the last 10, while I have been in New Hampshire watching the syringe service programs begin, grow, our overdose death rates are down. This works. In Laconia alone, in their hospital, they saw a reduction in blood infections from 6 a month to 1 every 3 months as a direct result of their syringe service programs. These programs work. I do agree. I wouldn't want a needle in the park where my grandson was playing, but ending syringe service programs in our communities is not the answer to the needle in the park. And the other thing, like, nobody has said, and I'm not an expert on this stuff, but if I'm giving out 100,000 needles and I'm getting back 600,000, those 600,000 are in the park. So instead of focusing on that, like, let's focus on what can we do as a community to get those 400,000 out of the park throughout the state, right? Like, there's a lot of good being done by people bringing them to us.
So your time's up, but I'm going to ask you.
Yes.
I mean, you've heard a lot of the testimony so
Yeah.
far,
Yeah.
and you just said, let's focus on getting those out of the park.
Yeah.
How would you propose to do that?
I believe that people much smarter than me today can give you strategies for that. But I will say the woman who talked about what they did in Vermont, I know they do that in Connecticut. They have, disposal sites that are full. People will use them if we do it, right? Imagine the cost of a red box compared to the cost of HIV and hepatitis C spreading throughout the state. Like, we have made huge strides in the last 12 years between 2014 and 2026. And if we stop doing the things that we are doing, you know how fast that will go up? 2 years, max. You will be back to the second highest overdose rate per capita. Like, we can't stop doing what we're doing. It's working. So.
Great, thank you. Are there any questions from the committee? No, thank you very much.
All right, anybody can reach out.
All right.
Thank you.
Eve Freeman Toth.
Thank you for allowing me the opportunity to speak. My name is Eve Freeman Toth. I'm the Street Outreach and Stabilization Manager for the Belknap Merrimack Community Action Program. I'm also a person with lived experience. I'm also somebody's mother. A field-based perspective on harm reduction policy. As a former harm reduction program manager, current homeless street outreach lead for 2 counties, from a frontline service perspective, harm reduction policies operate very differently in practice than they do on paper. Street outreach and harm reduction programs are not theoretical systems. They are applied in unstable, unpredictable environments involving people with complex trauma, co-occurring mental health conditions, and housing insecurity, and limited access to health care. When legislation proposes changes to harm reduction frameworks, several practical considerations are worth Understanding to avoid unintended consequences. The first of which, trust is the primary intervention. Outreach and harm reduction work relies almost entirely on voluntary engagement. Trust is built slowly and can be lost quickly. Even small policy changes that increase perceived surveillance, conditionality, or ambiguity with about legality can cause people to disengage, not because they are opposed to services, but because uncertainty feels unsafe and reduces the engagement. What this means to the rest of us is less contact with healthcare and more diseases, fewer opportunities to prevent overdose prevention, increased isolation, which raises mortality risk. That is what causes the needle in the stoop. 2, service displacement does not eliminate risk. When harm reduction access is restricted or altered, substance use does not stop, it relocates. Outreach teams typically observe this in person. We see increased use in hidden or unsafe locations, which is what Senator Murphy described. We see reduced bystander presence during overdoses, which equals higher rates of mortality. We see greater strain on emergency responders rather than fewer calls. These shifts unfortunately increase public health costs and emergency system utilization. Outreach workers absorb downstream impacts. Policy changes often assume agencies can adapt, but frontline programs operate with fixed staffing, limited funding, and strict compliance requirements. When engagement drops or behaviors change, outreach teams are left managing higher acuity medical crises, more frequent emergency interventions, increased staff burnout and turnover. None of these effects are immediately visible during the legislative review, but emerge months later. And that's really what I want to talk about, is the unintended consequences if you decide to kill these funds. And to add a personal sentiment, I will tell you that I'm a lifelong resident of Manchester and have personally observed since the Queen City Exchange launched a reduction in needles in my own park. I live at the Dairyfield Park, literally practically on it, and just lost somebody on December 26th to one of these infections. We referred to him as Uncle Dad. He had raised 2 generations of nieces and nephews and died from a blood infection that could have easily been prevented had he lived in a region of the state that had more access to these types of programs. He died slowly and expensively at the Elliott Hospital.
I'm sorry for your loss. Are you available for questions? If there are any questions
It would
here?
be my pleasure, and I'd be happy to email the rest of my testimony here.
Yes, that would be fine. Any questions for Eve? No, thank you very much.
Thank you for hearing me.
Todd Schillinger.
Good morning. My name is Todd Schillinger. I am the interim director of Keene Serenity Center in Keene, New Hampshire Recovery Community Organization. I was born in Keene in 1963, October. 1 month later, tragically, President Kennedy was assassinated, and unfortunately, I don't remember what I was doing that day. I'm here to speak opposed to the bill that was proposed earlier. And I'm a person in long-term recovery. So what does that mean? It means October 10th of 2006, almost 20 years ago, I gave my mom back her son. I gave my wife back the husband she married 19 years earlier. And she stuck with me this long, so maybe next year we'll celebrate 40 years if things go my way. And I gave my son back his father. I oppose this bill because as of January 1st, I was asked to step into the role of the director of our center because he was on medical leave. And so in the first month, I've had to find a new location for us to move into because we are moving our location next month and take care of that with licensing and that, terminate 1 staff member. So it's been a ride. And today I get to speak here, and I'm honored to speak here. And I thank you, the chair and the board, for listening. I would like to, I handed out what I was going to say, but after an earlier testimony, you don't want me to read that. You've got copies, like was said, you can read. So I'll just say that at our center, 3 months of last year of distributing syringes, we were 100+% on returns, which means we took in more needles than we gave out. We have worked with the city of Keene, including the Keene Police Department. We supply the Keene Police Department with these little sharps containers. So if they come across something, they're safe to put it in there and then bring it to us. They also know they can call us. We've alerted the fire station as well as the police station. If anybody calls and they need them picked up, that we will go and pick them up. We've worked with Keene Public Library. They allowed us to put sharp containers in both bathrooms. We worked with 2 different playgrounds and a basketball court in the Keene area that sharps have been found in the past, and we put up boxes there and we routinely maintain them to do our part. It's what I've learned here, because I came here and the senator to the proposed bill, Senator Murphy, I emphasize on his feelings because I too, like what was said, wouldn't want to come out and find, syringes in my car and all that. And when I came in, I was in here because of being a 12-step abstinent based. And so I'll just say that I've had education to know that that does work for some people, but harm reduction works also. And I've had to, change. And I'm grateful that you guys gave me this time.
Thank you. Any questions from the committee? Seeing none, thank you.
Thank you again for your time.
Jessica Carter, Revive, and Casey Larkin, you guys come together? All right.
Had several things prepared, but if we are being forced to, we will.
You need a little long.
Okay, thank. Good morning, members of the Health and Human Services Committee. Thank you for giving me the opportunity to speak. My name is Jessica Carter, Executive Director of Revive Recovery Resource Center and the primary operator of SANA, a comprehensive harm reduction program serving Greater Nashua Public Health Region since 2018. My face is on those pages in front of you, and our staff are responsible for those numbers you read. We are incredibly proud of them and those numbers. Because to us, those numbers indicate people who were given an opportunity to make a better choice for themselves, and hundreds of those unique individuals have sought recovery through treatment programs in 2025. We provide our recovery-focused programming through our multiple centers in Nashua, Manchester, and Derry. Our harm reduction offerings are limited to pre-approved areas while in outreach on the streets of Nashua outside of drug-free school zones. We collaborate on this program with outreach workers from the City of Nashua, the Doorway, and St. Joe's Mobile Health Clinic. Our outreach workers, city outreach workers, Nashua PD, Nashua Fire all collaborate on syringe pickups. We all work together to make sure syringes are never left unattended, and partners in Nashua know that they can call us to pick them up, which is why we now have a 100% return rate. It's also important to note that we are currently one of the few recovery service providers inside the walls of the Hillsborough County House of Corrections, as well as the peer recovery support provider for both Hills North and Hills South recovery court programs. This bill would make us either face shutting our harm reduction programming down or ceasing all programs completely. We're here to speak today in strong opposition to SB 549. This bill would not only defund syringe service programs, it would defund every program that Revive provides that's life-saving and delivers every day. If this bill passes, it will immediately destabilize the entire continuum of care in Southern New Hampshire. The scale of who we serve, just in 2025 alone, Revive's center-based and community-based services supported 1,105 unique individuals. providing individualized one-on-one recovery support, both in person, in the community, inside the walls, and much more. The majority of our participant base at the time came to us seeking help while actively using substances. We welcome all regardless of recovery status upon engagement. SANA served 624 unique individuals in 2025, many of whom are unhoused, medically fragile, or disconnected from traditional systems. Together, our programs reached 1,224 residents of Greater Nashua in 2025. These are not duplicate numbers. These are real people whose lives intersect with our programs because they have nowhere else to go. Documented, measurable outcomes. From SANA's 2025 operational data, we recorded 434 overdoses reversed with our Narcan, just in Nashua, and that doesn't include the ones that was distributed through our centers. That's just harm reduction. 434 lives that would be lost if this bill was passed. Yes, we might have distributed over 260,000 syringes in 2025, but we took more than we gave out off the streets. I am born and raised Nashua, have 3 children in Nashua, and I'm very proud to do what I do today. So over 1,700 naloxone kits, over 1,000 xylazine test kits, over 1,500 wound care kits, and over almost 3,000 referrals to treatment. I'm sorry, not referrals to treatment, almost 3,000 referrals to either health or other healthcare providers in the area. We give out resource sheets to everyone who seeks our services. What this bill would do: overdose deaths would rise, HIV, Hep C, and other transferable diseases would increase. Hospitals will face larger costs for preventable infections and endocarditis. Syringe litter in public spaces will increase, not decrease, because we know that people are going to use whether we provide these supplies or not. So I'm not really sure where you think those syringes would go if we are not there to pick them up. People who rely on SANA and Revive at one point of healthcare access will lose all connection to care. Law enforcement, EMS, and emergency departments will shoulder these heavier burdens. SB 549 does not eliminate the need for these services. It only eliminates the programs that currently manage the risks and prevent the worst outcomes now. The human reality is that when someone receives naloxone, wound care, or sterile supplies, they are not being encouraged to use drugs. And I guess I'll end with that.
Thank you very much. Did you want to add? I'll give you a minute if you want to add something to that.
Yes, my statement will be very brief. I'd like to begin by saying thank you to everybody for allowing me to testify today. My name is Casey Larkham. I am also employed by Revive. I am Nashua local, and I wanted to testify on a personal standpoint. I'm a woman in recovery, and I myself am an individual that accessed harm reduction services, and very specifically the same harm reduction service that Jessica was talking about, SANA. I now aid in operating that service, and the ability to access that service was multi-beneficial for me. It was a pathway to recovery for me. I was able to enter recovery through the resource referrals and support alone, aside from the fact that it allowed me to use in a more safe manner and to have access to those safer supplies. It was more so the support and non-judgment of the people that were providing those services that honestly pushed me towards seeking recovery. I then went and received peer support services while I was still actively using. Through that, I entered recovery, began volunteering over there, and now I'm employed over there. And I've seen firsthand on a personal as well as professional standpoint the difference it makes in the safety of our community and for that vulnerable population alone.
Great, thank you. Are there any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. Do you keep data on, I don't believe that this is enabling.
Thank you.
So what I need is data on people that you work with. How many people find, like yourself, find their way out?
So for our harm reduction programming, we don't collect very specific data on that, and for one very important reason alone, we're there to provide harm reduction services that prevent the spread of a disease. We're not necessarily there to talk to them about recovery. We do provide the referrals, and I do collect some anecdotal data, but we don't always know if people go. And that's because we are an anonymous program, and so like asking someone to fill out an ROI when we're sitting on the corner of Temple Street, it's not really, easily done. And so we really don't know people's names, numbers. We don't collect ROIs. And so we do have, around 150 people sought treatment from SANA this past year. But again, that's not a very, you can't really count on that number because it's all hearsay. At the end of the day, I have no confirmation that they actually went, they actually completed, and, have transitioned to a positive supportive environment after that. I don't really, there's not a way to effectively track that. We count our successes with overdoses reverse, with Narcan we get out there. When we're, helping people learn how to effectively use Narcan, you'd be surprised because I'll quiz people while I'm on outreach, people that are actively using. 98% of people don't know how to effectively administer Narcan, and it's causing harm in our communities right now.
Very good, thank you.
Any further questions? Seeing none, thank you very much. Representative Newell, I apologize. Your name was on the second sheet. Otherwise, I would have had you speak at the beginning. So I apologize for missing that.
It's okay. I'm very happy that much of my testimony has been covered already. So I'll be brief. My name is Jody Newell, and I represent Cheshire 4 and Keene. Very glad to have Todd from Keene Serenity Center come and speak today, particularly around disposal. We've done a really, really good job. All of us came together and now have disposal sites. We had an issue with needles being in a variety of places, and we're able to connect with our local harm reduction organization, recovery community organization, to be able to address that issue, and it is much less now. I think what that indicates is that rather than defunding, it would be better to increase funding at the end of the day, because these harm reduction organizations do actually remediate the issue that we're talking about, and with more capacity, they could do that more effectively. So considering so much of what I was going to say today has been covered, I'll just say this. So I'm a representative. I focus on opioid policy. As a matter of fact, I'm an NCSL opioid policy fellow from 2024. This is a key part of what an evidence-based holistic approach to reducing overdose deaths and saving lives is composed of. This is an essential point. If we take this out, we, as other people have said, we risk the chance of increasing overdose deaths. But the reason I'm so passionate about this is because I'm a person who lost my children's father to heroin overdose. 17 years ago, Christmas Eve, I knocked in that door, rammed in that door with a 9-month pregnant belly. Our second was born 2 weeks later. Todd earlier said that when he got sober in 2006, he gave his mother back her son. And I just wanted to say that my kids, because 17 years ago, these type of tools were not available, were not accessible, my kids will never get their dad back. I call her my soul mom because we were never actually married, we were engaged. My soul mother will never have her son back. These are tools that keep people alive, that keep people safe long enough until they can find a place where they are ready for recovery. And I think what we do is we forget that at the end of the day, when someone dies, there's no more opportunity for that. And that has an exponential impact on people like my children, on myself, on Corey's family. When we risk death, we are not just risking, it's bad enough for that individual, but we are risking an increased impact on the entire community. It radiates out to the entire community. So as I said, I think a lot of my points have been covered, and I just kind of wanted to bring it back to what the impact and the personal and societal risk that we risk when we reverse policies like that.
Great. Thank you, Representative. Thank you for your testimony. Is there any questions? No, and again, I apologize for.
No, it's
for not
okay.
getting to-
All right, thank you so much.
Carrie Nolte.
Thank you so much for the opportunity to speak today in opposition of SB 549. Dr. Carrie Nolte, I'm an associate professor of nursing at the University of New Hampshire and a family nurse practitioner at Greater Seacoast Community Health, in which I do healthcare for the homeless and mobile outreach. My program of research, my PhD is in nursing, and my program of research focuses on reducing drug-related harms. I collaborate with the amazing team of superhumans that have all testified today prior to me in conducting that research and understanding the health needs of people who use drugs to optimize care for them. I did submit written testimony by email, and many of the points have been covered. So I'm happy to answer any questions. Do further research on if the committee wishes. But in general, the benefits of SSPs are well documented. We see a 50% reduction in new cases of hepatitis C and HIV with these programs, and we see fewer needles disposed of in the community and found syringes. Annually, we plan to, my team and I, conduct a health needs assessment at all of the harm reduction programs in the state. Most recently, that was last April in 2025, in which we engaged almost 300 individuals who use harm reduction services to better understand their health needs. So a few points that I think are helpful to understand who's coming to these services. The majority, 82% of folks, have health insurance. They have been connected by these programs to all of the health services or to access these health services that they need. 3/4 of them have been tested for HIV and HCV, have a primary care provider who they see regularly. And many from our data collection in 2022 have actually transitioned away from injecting drugs through these programs. So when we had previously done data collection, 95% of harm reduction program participants were injecting. In our last survey, only 56% of them were actively injecting. So why are they going to a harm reduction program? They are getting supportive care, they're getting relationships, they're getting naloxone, they're supporting their friends, they're getting wound care kits. This bill would absolutely decimate all of these services that you've heard about today. The leading cause of poor connection with healthcare among survey participants was previously being treated poorly because of their substance use. 1/3 of participants reported that is why they don't access care. The other barrier was transportation. These are things that this supportive relationship at harm reduction programs is critical in establishing. These folks have a high burden of endocarditis and sepsis, with 300 of these participants, and 10 to 20% have experienced these conditions. That's often the entry point as people seek to enable their health and safety that they enter these programs. May I have just one more?
Wrap it up.
Okay. One additional program that I thought was of interest, especially given the prior testimony, is evaluation of community needle disposal. I've been collaborating with Dover Police Department and many community agencies on assessing the impact of 911 calls or emergency services calls for found syringes in the community. And over the 2 years since implementation, those have decreased 40%, representing additional time that officers are able to do what they're hired and trained to do, which is community policing. That is in the written testimony, and happy to take more questions about that data after you have a chance to review.
Thank you. Are there any questions from the committee? So I finally got around to looking at some of the stuff that Senator Murphy sent. You talk about the different things that you're doing. A boofing kit, is that something that's used widely?
I wouldn't say widely. I think it's something that is used to diminish credibility of programs, but in general, with injection drug use, you see the highest peak of the substance entering the body. So people who inject opiates may be injecting 10 times a day. So it's 10 needles they need in order to be safe. One strategy to decrease use is to use other routes. So that can be smoking, snorting, swallowing, or rectally, which is what boofing speaks to.
Okay, thank you. Any other questions? Thank you very much. Last person, Rachel Potter, I've got.
Thank you. For the record, my name is Rachel Potter, and I serve as Policy Associate at the ACLU of New Hampshire. I'm here today because we are deeply concerned about this bill, particularly its restrictions on the use of state and local funds and the liberty implications that flow from those restrictions. At its core, the bill is not simply about paraphernalia. It is about limiting how government can respond to a public health crisis in ways that respect individual dignity, bodily autonomy, and equal access to life-saving services. This bill would prohibit state and local governments from distributing quote-unquote drug paraphernalia and from using public funds to support organizations that distribute this paraphernalia unless the spending is specifically appropriated by the legislature or allowed during a disease outbreak. And that is a sweeping limitation that inserts the legislature into the day-to-day public health decisions these organizations are doing and removes flexibility from the professionals charged with protecting our community well-being. The concern is really compounded by how New Hampshire law defines drug paraphernalia, and that definition, as others have spoken about, is extremely broad, and that breadth can capture not only items associated with illegal drug use, but also harm reduction supplies that others have mentioned before me. And when a broad definition is paired with a strict funding prohibition, that result is a chilling effect on the lawful evidence-based health services that others have spoken about today. And organizations may scale back or avoid offering services out of the fear that that public support could be questioned or withdrawn, even when those services are legal and medically supported. And we know that restrictions like these often fall hardest on the people who are already vulnerable, people with substance use disorders, people living in poverty, and communities that historically experience unequal enforcement of drug laws. And limiting access to publicly supported harm reduction services can deepen our health inequities and reinforce stigma rather than promote recovery or safety. And our concern is that when the government withdraws support for preventative care, it effectively narrows some people's practical access to health-preserving resources, while others retain full access to care and protection. And finally, prevention is not only humane, but practical. Syringe service programs and related interventions are widely recognized as cost-effective and life-saving. I know that others have pretty much covered that testimony. And denying or restricting funding for these services does not eliminate substance use. It simply increases the likelihood of disease, death, and higher downstream public costs. A public health crisis should be met with public health solutions that respect human dignity and promote equal access to care. And harm reduction and liberty are not in conflict with community safety. They are a part of it. And policies that keep people alive, reduce disease, and connect individuals to care strengthen both public health and our New Hampshire values. So we urge you to find this bill inexpedient to legislate.
Thank you very much. Are there any questions? Thank you very much. That is the end of the list. Is there anyone else that would like to speak on Senate Bill 549?
My apologies, I thought my name was on the list. I'll make it very brief because I think the points that have been made today in opposition.
Actually, I think I did miss you. I apologize. Did Jake want to come with you, or is he, he's going to be next? Okay, I did miss you, so we'll let you speak and then we'll get to Jake too.
Okay, great. I was worried about what list I was going to show up on. My name is Kathy Stratton, for the record. I'm speaking on behalf of the New Hampshire Medical Society and our 2,000 physicians.
I want to speak in opposition to this bill. We're concerned about the public health resources, the value of them, and that they're part of a comprehensive effort to reduce addiction, overdose deaths. I share the concerns that have been expressed today about improperly disposed of needles and the public health risk that this creates, and offer our help and our services to help mitigate that and to resolve that. I want to say that in this, the National Institute of Drug Addiction has studied programs like this for over 30 years, and their research shows that programs, that needle syringe exchange programs, do not promote, encourage, or encourage or increase intravenous drug use. This is a critical bridge to the addiction community. It's part of a comprehensive harm reduction. And when we fail to meet people where they are, our physicians have learned that we can expect increased rates of transmission, delayed healthcare treatment, and increased costs of that treatment, increased duration of addiction, and increased numbers of overdose. The cost of human life, increased pressure on healthcare systems in ERs, and increased cost of medical care is high. And we ask that you vote ITL on this bill and shift the focus to the problem at hand, which is disposal of syringes. Thank you.
Great. Thank you, Kathy. Are there any questions? Thank you very much.
Thank you.
And Jake, I missed you as well, too, so I'll have you come up.
Thank you very much, Mr. Chairman, honorable members of the committee. I'll be very brief. My name is Jake Berry. I'm the Senior Vice President at New Futures, a nonpartisan nonprofit health policy and advocacy organization. We've been working for more than 30 years to help address substance misuse and addiction in our state. Let me start by noting, as you've heard over and over, that needle exchange is an evidence-based practice based on more than 30 years of public health research and evidence. It plays an absolutely critical role in preventing the spread of infectious disease and saving lives in our state. We've heard several times today about the falling overdose rates in our state, and we should all take a great deal of pride in that. But in my opinion, nobody deserves more credit for that than our harm reduction and our needle exchange programs. They distribute more Narcan, more doses of Narcan to individuals using drugs than anyone in our state. They provide community overdose prevention and reversal education to police departments and other community organizations. And they provide an endless number of resources to people who are struggling with substance use disorder. This bill would simply gut everything that they do. It would undermine the work that we have done to build a public health system capable of overcoming the addiction crisis, and frankly, it would cost us many, many lives. And lastly, I would like, taking off my professional hat as a lifelong Manchester resident, and I'm raising my children in the city. I take some exception to the characterization of Manchester that was offered earlier this year. I take my children downtown. We play in the city parks. We use the city ball fields. Certainly, on occasion, we stumble upon a needle, but they are few and far between. And to be frank, I feel much safer raising my children in a city that has programs like this available than I would otherwise if this bill passes. And certainly I would much rather my children stumble upon a needle than body bags. And I think that's the alternative. And I'm happy to take questions.
Thank you. Are there any questions of the committee? All right. Thank you, Jake.
Thank you.
Anyone else that would like to speak on 549? Okay.
I was on the list, I'm sorry.
What's your name?
Lauren McGinley.
Oh, you didn't check the speaking box. I'll check it for you.
I'm so sorry about that. So my name is Lauren McGinley. I am the Executive Director of the New Hampshire Harm Reduction Coalition, the organization that has been brought up many times in this conversation. I have testimony. I have submitted it online, so I would be happy to cede my letter. If there were questions that people had, there seemed to be a lot of questions, and I would be happy to answer them.
Sure. Do we have that testimony, Sophie? Do you know?
Sorry, I can submit it
Oh,
online.
okay.
I have it
Yeah.
typed and ready to go.
Well, you got 3 minutes, so.
Sure.
So instead of going through kind of the history of what harm reduction has been in the state of New Hampshire, I can just briefly summarize that by saying it's relatively new. While it is new in New Hampshire, though, it is not new nationally. For 30 years, the CDC has been proving the efficacy of syringe service programs at both reducing fatal overdoses, reducing non-fatal overdoses, which is not spoken about enough, in my opinion, and reducing things like syringe litter in communities, reducing the infections of HIV, hepatitis C, and other bloodborne pathogens, as well as reducing a serious and significant reduction in costs on hospital and medical systems as a result of people not getting wounds and abscesses from their injection drug use, which is a very common ailment when people are unable to access sterile syringes. To speak on that point, it was not brought up. In New Hampshire, syringes are perfectly legal to sell. Pharmacies across the state sell them. You do not need a prescription. I did double check before I came up. I have Amazon Prime. I could get them delivered to me tomorrow. 100 would arrive and it's $20. That's to say, syringes will be here whether or not these programs are. We are the only organization in the entire state that provides free access to biohazard disposal for syringes. Now, the majority of our syringes absolutely are coming from people that we provide them to for these services, but we will take anyone's syringes, and we commonly do. We have somebody who gives their cat insulin twice a week, and so we've been taking their syringes for as long as we can. People are also acquiring syringes for a whole host of other things. We've seen this in the last year, especially, that people that are utilizing injectable drugs from third-party pharmacies, such as GLP-1 drugs, they're encountering and creating a substantial amount of syringe, what we call syringe litter, and do not have the resources or the education of the appropriate places to throw them away. So we understand and fully know that there is a syringe litter issue in different areas in our state. I would caution anyone to assume that if we ceased syringe service programming, that syringe litter would improve. So I will stop there. I am happy to answer any questions. I know there were some questions about funding.
Are there any questions from the committee?
No, great.
You're out, you got loose.
Additionally, I brought our entire annual report with me. I'm happy to pass that out if anybody would like it. That seems to be a print off and not a total
Okay,
one.
yeah, if you want to leave it with the committee
Excellent.
staff, that would be great.
Thank you all very much.
Anyone else that would like to speak on 549? With that, I'm going to close the hearing. All right, we're going to open the hearing on Senate Bill 616 relative to reporting requirements under the Right to Try Act. Ask Senator Prentice to introduce her bill.
Thank you, Chair Rochefort and members of the committee. For the record, my name is Sue Prentice. I am I'm the state senator for District 5. I almost used my title for my full-time job. I had to stop myself. Covering 15 communities. And I am here today to introduce Senate Bill 616, which is placing reporting requirements on the right to try, statute. And I think you all know that last year, House Bill was 701 built on what was already right to try statute basically built in some expansion. And I supported that bill and continue to support it because this right to try allows for folks who are terminally ill, that have exhausted all FDA approved options. There's no other option available to them. Anything that's been approved by the FDA isn't, and there are experimental options that they choose to enter into. This provides them with that mechanism and that protection to do so. But I think that a blind spot in this, and I picked it up literally as we were kind of leaving last year's session, is that unlike other healthcare, treatments, facilities that provide treatments and such, there's no reporting requirement that's been built into this. And there is a possibility we could extrapolate some of that data, but it's going to really depend on the setting. So I wanted to bring this forward, and it's I'm always cautious when somebody says that something is simple, but I do think this is relatively simple. So let's remember that right to try is important because they're outside of the clinical trials. They were talking about using investigational and non-standard therapies. This could involve coverage denials or self-pay. And as we heard during the testimony for last year's bill, HB, again, I believe it was 701, that people potentially will travel to the state because we have a more expanded program with this type of coverage. So I think we want to know some things about, where folks are coming from, what kinds of medications or therapies are being used, who is administering them, and the settings that those are happening in. Again, I pointed to, we do collect data in other healthcare sectors. We have the ambulatory care data set. We have the outpatient data set. And we also, Emergency Medical Services does collect data on every incident that they encounter. Some of this is, there's ways to pull from that data, but I don't believe some of the pieces, well, I know that some of the pieces that I'm asking for quite simply in this reporting are not covered in here and could be lost. So I wanted to be more specific about it and give the department the ability to write rules related to it, related to this reporting requirement. I think it's also important to note that the fiscal note, it's important to note that the fiscal note for this, if we were to push out the effective date of this, would allow for the department when they are building, when they are building another statistics collection, another data collection system, that they could do these at the same time versus doing them individually, reducing the cost dramatically. So from a policy perspective, what I'm just trying to do is align this program so that we can simply get the data that we need should this program get the use that we have been told that it would get. And it, again, aligns with other healthcare reporting requirements. And there is a way, again, if we push out the effective date, that we can manage the fiscal note on this. I thank you for the opportunity. Some of you worked on this with me last year, and so thank you for the opportunity to revisit this and bring this in line with other healthcare reporting. Thank you.
Great. Thank you, Senator. I think I've got a question from Senator Birdsall.
Well, thank you. Thank you for taking my question. So on the fiscal note, because we had spoke about this earlier. So it looks like with the fiscal note, if you push it out to 2027 and you can dovetail on the abortion statistics piece, then the lower where it says 97 to 882,000. So it's going to be the lower end of all of those.
Correct.
Okay.
And if John Williams is still here, he can raise his hand, but he can speak about
He can nod too.
Yeah, and as long as he's nodding, then we're in line. Yes.
Thank you.
Thank you, Senator Birdsall.
Any other questions? I do have a question on that about the fiscal note, and I think you and I spoke about this. I find it hard to believe that the department will need to hire somebody to do this. And, looking at the fiscal note, I understand they want to make sure that all their bases are covered, but looking at the bill, what you're trying to do, I think if somebody was hired, they'd be bored for a lot of the day. We hired them to do this because I don't think there would be that much there. Any thoughts on that?
I think that, so thank you for the question, Senator Rochford. I think that you build out you build out in a preventative and protective manner. So it may not be that they need one full-time person, but when coming forward with a fiscal note, you have to assume all possibilities and then have the opportunity to work on the fiscal note as well as, when you work on that and you dig down to the detail, sometimes you're able to bring this to maybe, where it could fit into some other position. The department would have to speak to this, or maybe be a half-time position, but you start with the high end and then work to see where you realistically land. And sometimes, I think, as we all know, that happens somewhere between here and the Finance Committee.
So it sounds like you share my skepticism that this would not require a full-time employee.
So
And you don't have to answer that question. All right.
I have a lot
thank
of
you.
respect for the department,
Yep.
but I understand. Yeah,
Thank you. Is there anyone else that would like to speak on Senate Bill 616? All right, with that, I'll close the hearing. I have a motion to go into executive session.
Second.
All those in favor say aye.
Aye.
Any opposed? All right, I move ought to pass on Senate Bill 616.
Second.
We have a motion and a second. Any discussion on that? We want to put a committee amendment to
push out the
the
effective date.
effective date.
Oh, yes.
So I would put forward a committee amendment. And Sophie, I probably should have checked with you before we went into executive session. Let me know when you're ready.
I think we see John Williams.
All right. John, do you want to talk before we?
Senator Rochford, just to address the issue about the amendment, if I draw your attention, as I get my glasses on quickly, to the reporting requirement, you'll need to make the adjustment on that line on the bill, and that is found on line 20. So the date for the February 1st, 2027 would have to be adjusted for 2028. Then the effective date on line 31 would reflect the same effective date that we're looking for on a couple of bills that are out there to address the timing issue for implementation of the abortion statistics reporting bill, which is July 1st of 2027. So those changes need to be in both of those places.
So on line 20, it's February 1st, 2028.
That is correct, unless Senator Prentice had a different thought. It would at least take us approximately 6 to 8 months to stand up the database.
And the effective date is 7/1/27.
That is correct.
And this would bring this, Senator Rochford.
Yeah, go ahead.
This would bring, as talked about earlier, align this with another project that the department's working on, therefore to say be a more cost-effective, efficient way of building a system.
Yeah, and in fact, in this committee introduced is Senate Bill 474, sponsored by Senator Birdsall, the department's request to make the adjustment on that other item to July 1st of 2027.
Very good, thank you. All right, Sophie, you ready? I'll move a committee amendment to change February 1 on 2027 to February 1, 2028. And then the effective date on line 31 is 7/1/27. And that's my motion. Senator Birdsall seconds it. Any further discussion on the amendment? All those in favor say aye.
Aye.
Any opposed? The motion is ought to pass with amendment. All those in favor say aye.
Aye.
Any opposed? So could move, Senator Birdsall moves consent. Senator Prentice seconds that. All those in favor say aye.
Aye.
Any opposed? And I'm giving this to Senator Prentice to take up.
I will, thank you.
All right, motion to come out of executive session.
Second.
I got a motion and a second. All those in favor say aye.
Aye.
All right. Okay, I'm going to open the hearing on House Bill 349 relative to the practice of optometry and authorization to perform ophthalmic laser procedures. And we will have a 3-minute, after the prime sponsor and any department speaks, we'll have a 3-minute limit on testimony. And I'd like to call Senator Copal to introduce his bill.
Thank you, Mr. Chairman. Thank you, members of the committee, for hearing my testimony. For the record, my name is Jim Copal, representing Hillsborough County District 32, comprising the towns of Wilton, Temple, and New Ipswich. I'm here today to introduce House Bill 349, which expands the scope of practice for licensed optometrists to perform 3 very specific ophthalmic procedures, laser procedures, provided that the practitioner is first certified by the Board of Registration in Optometry. Some of you may recognize the elements of this bill that are similar to the provisions in Senate Bill 440 from the last session, which passed the Senate on a voice vote and came out of this committee, or came out of committee in the House with a recommendation of ought to pass. While that expanded the scope of practice for optometrists in a number of ways, this particular bill is far more limited. It's limited to 3 very specific laser procedures for which optometrists are trained but are currently not authorized to perform in the state of New Hampshire. It is also worth noting that optometry is the only profession for which permitted procedures are delineated in statute. And although that seems problematic, this bill is not attempting to address that particular situation. Another change in this bill came from a House amendment. The House amended the bill to add live patient training requirements and successful completion of multiple instances of successful procedures under proctored supervision. So there are some very specific training requirements that come with this. So the 3 specific ophthalmic laser procedures are laser capsulotomy, laser trabeculoplasty, and laser peripheral iridotomy. This also authorizes the Board of Registration in Optometry to adopt rules, including minimum education training and hands-on experience, criteria for proctoring, and outcome reporting requirements. So with that, I'd like to go into why House Bill 349 is important to people in the Granite State. First and foremost, access to care. Rural areas in our state face significant shortages of ophthalmologists, and the number of people practicing ophthalmology is declining, whereas the number of optometrists is actually increasing. Average wait times for these specific procedures can be between 3.5 and 4.5 months on average in New Hampshire. And some patients, particularly those in the North Country, have to travel long distances to get the care they need. To make matters worse, patients who are undergoing eye procedures are sometimes unable to drive themselves to and from appointments, which means that they then have to make arrangements for transportation. This bill would reduce wait times. It would reduce those travel burdens, and it would have a very real impact on people's lives. So one such story that I'd like to share is a retired 77-year-old who lives in a rural area of New Hampshire. She has vision in just one eye and was unable to drive, became dependent on others to perform the most basic of errands, like grocery shopping, banking, and taking her to and from social activities. And there was a pretty significant wait for her to get these procedures. So access to care by passing this bill would alleviate some of the burdens on Granite Staters like her. HB 349 also has the potential to reduce healthcare costs, because obviously when there's increased availability of care, that can lead to lower healthcare costs as patients have a greater range of options. One of the concerns about this is, we haven't seen optometrists perform these procedures in this state in the past. In fact, some of the optometrists in New Hampshire have been authorized and have performed these procedures in other states. And in fact, if we want to welcome optometrists to move to New Hampshire and practice in New Hampshire, we should allow them to perform their duties to the fullest extent that they are trained to do so. 14 states currently allow optometrists to perform these procedures. Optometrists in Kentucky, Oklahoma, and Louisiana have safely performed these for well over a decade. And Oklahoma, I believe, was the earliest to allow these procedures, and that dates back to 1998. Evidence from other states indicate that adverse events in just 2 cases out of over 146,000. So that's a rate of about 0.001%. By comparison, the average American's odds of dying in a car accident are roughly 10 times that. We actually don't know whether ophthalmologists have a similar rate of adverse effects because, as I was doing research, I was not able to find any data. Presumably that number is not 0. So 2 cases out of close to 150,000 versus, I don't know what the number is for ophthalmologists. Malpractice insurance there's no difference in malpractice insurance rates for optometrists who perform these functions versus those who do not. So the people whose careers hinge on accurately quantifying risk have determined that there is no additional risk here. If this bill does become law, we have a board of registration of optometry that can set guidelines, administer proctored training, and assure that patients remain safe. So with that, I urge the committee's support of House Bill 349, and I'm happy to take any questions.
Thank you. Are there any questions? Senator Birdsall.
Thank you. Thank you, Representative, for taking my question. In those states of Kentucky, Texas, and Oklahoma, do we know what the requirements are for them to get trained or certified in the laser?
Thank you for the question. I don't know. There may be some people coming after me who will be able to answer those questions. I do know that optometrists, generally speaking, are performed to train these to perform these procedures. I'll also note, contrary to some of the statements made by members on the House floor, these are not procedures that involve cutting into the eye. These do not involve any kind of incision. They don't require an OR or any special facilities. These are typically performed as outpatient procedures in an office setting and are considered to be extremely low risk, as the statistics that I provided would indicate.
Thank you.
Thank you.
Just going back to page 2, lines 1 through 4, where it's defined on, how many of these procedures have to be done, a minimum of 5 capsulotomies, 5 trabeculoplasties, and then I should know better. Where did those numbers come from? Are those based on a standard of other states? How do we settle on those numbers?
I was not involved with the House amendment process. I expect those probably were based on what happened in other states or what's considered a reasonable standard for
And maybe someone coming up will
live
be able to
training
answer that.
practice.
Yep.
Yes.
Yep. And if you can, there's your prompt right there. So,
all right.
Any other questions from the committee? No. Thank you very much.
Thank you.
So I've got, and just a reminder, we'll be having a timer for 3 minutes. If you've got written testimony, I would advise you to use better use of your time than just to read something. You can submit that and summarize your testimony in your own words. And if there's been a point that's been made, there's no point in making that over and over and over again. Again, that's just some advice on wise use of your time. So with that, I'll call Dr. Allison Loringer.
Hi, okay. Thank you for hearing my testimony today, Mr. Chairman, members of the committee. I grew up in Bedford. My name is Dr. Allison Laranger. I went to West High School, then UNH, and graduated from the New England College of Optometry in Boston. I now live in Goffstown, and I spent 15 years working alongside ophthalmology before opening my own practice, Advanced Eye Care, in Hooksett in 2020-25. I'm here to ask for your support of House Bill 349. Optometric scope of practice in New Hampshire has not seen a significant update in more than 20 years. Meanwhile, optometry education and training has advanced nationwide. This bill simply brings our state in line with the modern standard. These are in-office laser procedures already performed by optometrists in 14 states. And since then, as you heard, hundreds of thousands have been performed safely. Other things that you may have heard is that they are not operating room surgeries. There's no scalpel. There's no general anesthesia. This is not LASIK, and it does not lead to cataract surgery. These lasers are only for the front of the eye. Optometrists are not trained in retinal lasers, and they are not in this bill. Historically, organized medicine has opposed scope expansions for any non-MD providers, and optometry is no exception. The American Medical Association's Stop Scope Creep campaign is specifically designed to restrict other providers with the same rhetoric that any non-MD is not trained or poses a risk to patient safety. The same warnings were made when optometrists sought authority to treat glaucoma 25 years ago and decades earlier when we were asking to simply dilate patients. Each time, predictions of widespread harm were made, and they have never come true. You may hear concerns about referrals and patient selection from our opposition, but just as not every ophthalmologist performs every procedure, not every New Hampshire optometrist would pursue laser certification. Some will continue to refer to certified providers who would determine the candidacy. You may also hear concerns about complication management. The most common complications are inflammation, pressure spikes, and minor intraocular bleeding. These are patient conditions that optometrists already manage every day in routine care and postoperative care. Rare, severe complications require a referral to a retina specialist, no matter who performs the procedure, whether it's an optometrist or an ophthalmologist. We have repeatedly tried to collaborate with ophthalmology, and they have refused. Instead, they just rather oppose than participate in any constructive discussion or solution. Optometry has made several adjustments to strengthen this legislation and address concerns in good faith. Ultimately, this bill is about access to safe, effective eye care while maintaining high standards for New Hampshire patients. Thank you.
Thank you very much. So you heard my question earlier about the number of procedures that are required for, certification. Do you have an answer to that?
Yes.
Okay. So where do we get these numbers? 5, 5, and 4.
These are the minimum numbers required in ophthalmology for ophthalmology residents to be able to perform these procedures. They have to do a minimum of 5, 5, and 4. So we
Okay.
matched those minimums.
Great. Thank you. Are there any questions of the committee? Senator Birdsell.
Thank you. Thank you for taking my question. So, so we know what's required. Where will they get, where would you get the training to do these? And would it be like an internship of some sort?
The training right now, every single optometry school for years in the country has trained on lasers. And for doctors who graduate, like me, 15 years ago, and I didn't have laser training, there is continuing education that is obtained to learn how to use the lasers. And that is how all medical professionals advance and stay current, is through continuing education. And that is also how ophthalmologists learn new advances as well. And there are courses for us to take postgraduate to learn how to do these laser procedures. And then in the state of New Hampshire specifically, there are those live case requirements that we would have to fulfill.
Yes, follow.
Thank you. The other question I have, okay, so let's just say someone I know the schools that are teaching the later students now are doing the laser work, but let's just say there's someone who came out, didn't have the laser experience, so they go and they get training, then where do they go to get the practice?
Great question. So we have a few optometrists in this state who have performed lasers on live patients in other states or in the VA system. So those optometrists are some that could become proctors and then certify other optometrists while they're doing their live cases. And they would have to show competency before they're able to be certified. So those minimums are simply minimums. If someone needs a few extra cases, they need to do a few extra cases.
Yes.
Final follow-up. So are you saying that the VA does this?
The VA used to allow lasers, and then with the politics, it was stripped away. And it was not because of any case that came about or anything negative. They just stopped it. What the VA allows, though, still currently is in their community care program. They will send out referrals, and they will allow their veterans to have lasers by optometrists in the community. So that is an issue that's ongoing in the VA system.
Okay, thank you.
Any other questions? Thank you very much.
Thank you.
Kathy Stratton.
Good morning. My name, for the record, is Kathy Stratton. I'm the CEO of the New Hampshire Medical Society, representing our physicians and 2,000 plus members in opposition to this bill. It was slightly more than a year ago when we first testified about this bill, citing evidence of extending medical privileges to non-professionals that would translate into increased access in rural states, in rural areas of the state, and explaining that education and training of ophthalmologists make them uniquely qualified to perform laser eye surgery. I will share with you online, but I also will cite a few of the key points. The AMA has done a lot of research into the training of optometrists, the training of ophthalmologists, and how they're different. And ophthalmologists receive 4 years of postgraduate education, which optometrists do as well. Ophthalmologists 3 to 5 years of residency that includes direct experience caring for patients across specialties and a spectrum of diseases. There's none required for optometrists. Ophthalmologists continue with 12 to 16,000 hours of training. And I think the key here is that this is rigorous and standardized training. That I think we need to stop looking at the minimums and start looking at what you can expect when you visit your doctor's office. So before I jump into the majority of my testimony today, I want to share a personal experience that's relevant and takes us back to the heart of why I'm here today. In December, my 85-year-old mother required laser eye surgery to repair her vision. Though the skill and training and expertise needed to perform laser surgery is sometimes downplayed, I want to share that for my mother and for my family, that's what really mattered. The surgery meant the difference to her between independent living, being able to drive for her groceries, doing her crossword puzzles, researching our genealogy. The ophthalmologist in this case had one chance to restore my mother's vision so that she could continue to do the things that she loves and that makes her life meaningful. Her surgery was successful and her recovery is going well. As I sat in the recovery room, our opposition to this bill resonated in my mind. This bill would extend surgical privileges to professionals with limited training, limited surgical experience, and almost no medical oversight. If education, training, and experience matter to me and to you when we seek medical care, then those truths and values also have a place in this room for discussion. Can I have just a minute? Okay. So I just want to highlight that a lot has changed in the year since we first testified. These talented physicians, surgeons, business owners, and entrepreneurs have met the challenge before them of providing care in the North Country. They care about the well-being of patients in New Hampshire, and that's what we're here advocating for today. Please, we encourage you to ITL this bill. I appreciate your time and thoughtful consideration of the committee.
Thank you. Are there any questions of the committee? Senator Prentice.
Thank you. Thanks, thank you, Kathy, for taking my question. So just as you were wrapping up there, one of the things you were talking about is that you're talking about the training and that there wouldn't necessarily be I'm trying to think of the right word, but you were talking about supervision. But it's clear in here that that they are being supervised, by someone within their profession. The supervision is built in here for the training as well as staying, continuously credentialed or certified to do this. So
Thank you for your question.
It sounds like you're saying that that's not there.
No, and thank you for your question because it does require clarification. Medical supervision on the licensing board from a licensing perspective. Their professional licensing board does not include a physician.
Well,
Yes.
so thank you very much for that clarification. So that's different than, having that type of supervision on the licensing board, I think is something that we need to move towards. But in terms of the practicality of preparing somebody to perform this and keeping them properly prepared to perform this, they have that supervision.
Again, I can't speak to what they have or don't. That the point was not clearly stated on my part when I said the supervision relates to medical supervision in terms of licensure.
Okay. Thank you.
Thank you.
I just wonder if you could comment. I'm on the AMA website, and there clearly is a robust website. I would deem it Operation Scope Creep. Can you comment on that? Why is that a concern for AMA that, trained, we heard people that are trained in something, it feels like you're threatened by that.
Not threatened. I think it's important for my organization as physicians to represent what we feel and what we believe and what we see is good medical practice. And so we're not so much concerned with creep as we are concerned with what's safe for the general public. Our ophthalmologists have worked very hard in the past year to address rural healthcare, and I think that was the concern that brought this bill forward. They'll talk today about what they've done in the past year, what services they're being provided in rural areas. I mean, to me, that question has been asked and answered. And if the concern of this body and of the legislature was to provide quality medical care in rural regions, we've done that. And I don't think that we need to solve that problem with expanding scope to a group of wonderful clinical optometrists. I am not downplaying their role and their value in this, but I'm just saying that providing this particular service, this is surgery. We can't downplay the importance of this credentialing that we would be extending to them. The value of it, I think, isn't there like it was a year ago.
Thank you. I don't think there's any more questions. Oh, Senator Prentice has one.
Clarification, Kathy, I think I heard you say that there's going to be somebody who's going to speak specifically to what efforts have been put in place to expand access, because that continues to be a concern of mine representing, a rural part of the state.
Absolutely. We have ophthalmologists here that are prepared to testify. They've created a business that's open, operational, seeing patients in the North Country.
All right, thank you very much.
Thank you.
Dr. Larry Bache? Bache?
Good afternoon now. It's a real honor to be here. And my name is Larry Bache. I am an OD PhD. I have spent 35 years in ophthalmology, training residents and doing research and clinical optometry. And the last 8 years as the Associate Dean of Research and Professor at MCPH University School of Optometry in Worcester. And I'd like to tell you that I'm really looking forward to your questions. The education of optometry students in cataract, refractive surgery, glaucoma, laser surgery is extensive, deep, and thorough. Most of what I'm going to be talking about is on the last 7 or 8 pages of the handout that I sent out. In our school, our students get 176 hours of optometry methods and lab, didactic and refractive surgery. We're not doing refractive surgery. A lot of glaucoma, a lot of lab glaucoma, a lot of clinical glaucoma, observation of our ophthalmologist who does laser surgery in our state, which does not have laser privileges. And they do extensive training on the lasers on simulated eyes, as do ophthalmology residents before they see their first patient. After graduation, optometry students have to take certification courses, and then they need to take the NBEO, National Board of Examiners in Optometry, certification in laser surgery and minor surgical procedures. Once they pass that certification, which is very difficult, and the requirements are listed on my handout, then they will either do a residency in a facility where they can do laser surgery and can be proctored by ophthalmologists or experienced optometrists, or they can go to states where they can also be proctored. I believe the bill here, the Optometry Board's intention is to have ophthalmologists proctoring the optometrists and also experienced optometrists in laser surgery proctoring. It's very thorough, and the requirements will be the same as the ophthalmology residencies. One thing I would like to clarify is the fact that ophthalmology residencies do not require their residents to do those 5, 5, and 4 procedures. In order to get certified as a residency, the residency needs to show that that is available to their residents for training in lasers. Can I make one more quick point?
One more, because I've got some questions and I'm sure other people do here.
I am a physician trainer for the Luminous laser that does those procedures. I'm an official trainer for MD physicians. And I can tell you that physicians who have not done laser surgery in their residencies, I do a didactic for them, then they do simulated eyes, and then they do their first patient. And I supervise.
So you train physicians?
Correct.
OD trains?
I train physicians, and in many cases, a medical science liaison or a technician trained to train physicians will do the training for physicians.
Are you training them on these 3 procedures that are defined in statute?
Mm-hmm.
Okay. And then, and the reason I'm rushing you, because we've got this room till 1, and then we all have other meetings we've got to go to. But so you said at MCPHS, are students trained didactically on these 3 procedures?
Absolutely, and they get extensive
And it's not, they
repeated
graduate
overlap training.
on Sunday and assuming they pass their boards, they're doing surgery on Monday.
No,
You
no,
described a several step process that, okay.
No, they have many, many hours of didactic glaucoma. They actually have 2 semesters of glaucoma. And then in the cataract and refractive surgery case, they get the secondary cataracts, quote unquote, that the YAG capsulotomy is geared for.
Okay, thank you. Are there any other questions from the committee? I guess I was the only one. I spoke for them. And
Okay.
thank you very much.
Thank you very much for your time.
Dr. Peter Remillard.
Good afternoon. Thank you, Mr. Chairman and members of the committee. For the record, my name is Peter Remillard, and I've been practicing optometry for 37 years. It's true, I'm not as old as I look. I am licensed in Connecticut, Massachusetts, and recently New Hampshire. I currently practice at my eye doctor in Manchester, and I'm here today to testify on the safety, training, and patient protections in HB 349. First and foremost, I do want to say that no optometrist in New Hampshire may perform these procedures without specific board certification. This certification is in addition to the full New Hampshire licensure. The New Hampshire Board of Optometry sets strict standards through its rulemaking. These privileges are not automatic and they're not granted lightly. On training and clinical experience, laser certification builds upon 4 years of postgraduate doctoral education, which requires a dedicated laser education program, as you just heard, and live proctored patient cases with minimum numbers defined by the statute. However, meeting minimums does not guarantee certification. Candidates must also demonstrate clinical proficiency, sound judgment, and safe technique under supervision before certification is granted. Regarding patient protections and safety data, the bill requires informed consent, same as any other medical procedure in office. It also requires mandatory reporting of complications or adverse events should they occur. We now have data from states where optometrists perform these lasers, as was said earlier, more than 146,000 cases. Let me tell you that there's been no shown increase in complication rates and no shown increase in malpractice insurance rates. Do you think about that? Who would know best than the malpractice insurance companies? Leading to complications and risks. There's been recent discussion about licensure practices in other states, particularly with the Kentucky board. That board has board autonomy. New Hampshire does not have that. Let me be clear. What happened in Kentucky cannot occur in New Hampshire. New Hampshire board requires passage of all parts of the national board examination. It has no authority to waive those requirements. New Hampshire's regulatory framework is fundamentally different than Kentucky's. Complications can occur with any medical procedure, regardless of the type of provider. Fact is, similar complications have occurred when procedures were performed in the hand of ophthalmologists.
And I'm going to ask you to wrap it up as
Okay.
the timer went off. But if you want it, we've got, I'm assuming the stuff you're covering is in the testimony you submitted here?
is.
All right, very good.
Yeah.
Thank you.
So may I give you a summary real quick?
Real quick.
Okay. The framework of House Bill 349 includes strict certification, advanced education, supervised clinical experience, informed consent, and mandatory reporting. These are strong safeguards in this bill for the protection of our patients and to grant better access to high-quality eye care in New Hampshire.
Great. Thank you. Are there
Thank
any
you for your
questions
time.
for Dr. Remillard?
Any questions?
No, we're all set. Thank you very much.
Thank
And we
you.
have your testimony. Thank you. Dr. Angelique Sawyer.
Hello, thank you for your time. I will try and be very brief. Thank you for the opportunity to speak with you. My name is Dr. Angelique Sawyer. I'm an optometrist and practice owner in North Conway and in Berlin, New Hampshire, so in some of our more rural parts of our state. I've practiced there for the last 13 years, and I'm here to speak in support of HB 349. And again, this is primarily to address the serious and growing problem of access to timely eye care, as well as patient choice in healthcare. As mentioned earlier, we are seeing a decline in the supply of ophthalmologists. There are actually research that shows that ophthalmology is one of, it's the second worst among 38 medical specialties as far as workforce inadequacy that is predicted to come in the next 10 to 15 years. So not only do we have a shortage now, but that will worsen, whereas optometrists is a growing profession. They're growing at 1% per year. So in that same time frame where they're declining, we're expected to go up at least 10% in the next 10 years. Where I have been in the rural part of our state, I've seen the access issues when we first came forth with SB 440. We were looking at 4 counties in New Hampshire that had a total of 2 ophthalmologists for those entire 4 counties. In my time in the North Country, I have seen our largest referral center, Dartmouth Hitchcock Ophthalmology, close its doors to internal and external referrals for a period of time when they were not able to provide the care that was needed. In the North Country, I have seen ophthalmologists retire and simply close their doors without someone to take over. I've seen providers leave the area, and I've seen the hospital make attempts and fail to recruit a full-time ophthalmologist to meet the need in the area. For many years, we had an ophthalmologist traveling to provide cataract surgery, but that also reached a point where it was unsustainable for them to come 4 or 5 times a year, became too burdensome. I'm very grateful that the optometric legislation that we brought forth have led to the development of an ophthalmology outreach clinic at Androscoggin Valley Hospital in Berlin. And that will restore some access to cataract surgery. And it's even going to bring retinal specialists. That is a specialty we've never had access to in the North Country. So I am ecstatic that this program exists. But that program does not reduce the impact or negate the necessity for HB 349. The services being provided at the AVH Outreach Clinic are much broader than the 3 very limited scope laser procedures that are addressed in this bill. Even those laser procedures, when they are provided at that clinic, will require additional consultation repeat testing by providers that are not known to the patients that they need to see. Because it is a rotating schedule, many of the patients who will be seen in that clinic might be seen by somebody and then have to wait several months for that provider to rotate back again, or have a procedure done by somebody who did their initial consultation. So we're very grateful for this program, but it does not solve all the issues. We've seen efforts to increase access that have fallen short. I have been there for 13 years. We have many examples of patients that have had these procedures that will testify they're comfortable having their optometrist provide these procedures, knowing what it is entailed.
Thank you. Are there any questions for Dr. Sawyer? No, thank you very much.
Thank you.
Deirdre Cullen.
Hi, thank you for the record. My name is Deidre Cullen. I'll try to keep this short and sweet before the buzzer goes off.
We appreciate that.
I am an optometrist and business owner. I work in Belmont, New Hampshire. I am an example of somebody that graduated having been trained in these procedures at MCPHS University. And when I came to New Hampshire, I was unable to perform these skills. So I'm also now a business owner, and it's already difficult to find new hires, but when I have to tell those new hires or those candidates that they cannot perform these skills in New Hampshire as well, it makes it even more difficult to find qualified candidates or really top-tier providers that want to work in the state of New Hampshire. We will continue to lose those top-tier providers to other states that want to keep up with this evidence-based care. I want to quickly just talk about a study that came out in 2022 called the LIGHT trial, which stands for Lasers in Glaucoma and Ocular Hypertension Trial. It concluded that one of the lasers that's in discussion here, SLT, was safe and effective as a first-line treatment in glaucoma. So as optometrists in New Hampshire, we already have the ability to treat and manage glaucoma, but now we can't provide something that's considered a first-line treatment. That just doesn't make sense to me. And with, I'll just end with, ophthalmology workforce nationwide is declining. Optometry workforce nationwide is increasing, and so is the patient population. So I am in support of this bill, and I hope you will be as well. Thank you.
Thank you. I have a question, and then I'll open it up to the committee. So you were certified, or you went through laser training in school.
Correct.
You took your board exams and came to New Hampshire, and obviously we don't allow this.
Correct.
So what more would you have to go through the proctoring where you have live patients? And did you ever get to that point in your?
No, because that would have been something I'd have to do here in New Hampshire.
Okay. And then in New Hampshire, we have a board of optometry, and I'm assuming, and I don't know this, is there anyone on the board that has been trained to do this?
I don't know the answer to that question.
Okay. All right. We can find that out. Are any other questions from the committee? Thank you very much.
Thank you.
Dr. Shakti Maiden?
Good morning, Chairman and members of the committee. I'm Dr. Shakti Maida. I'm an ophthalmologist at Dartmouth Hitchcock Medical Center, and I've been in practice for the last 10 years. I'm also the current president of the New Hampshire Society of Eye Surgeons and Physicians. I'm here today with my colleagues to express our deep concern about HB 349. Outside the confines of this State House, optometrists and ophthalmologists work as a team. I myself see an optometrist every year and have done so for the last 30 years. But optometry is not a surgical profession. Their training is rather different from ours. They go to 4 years of optometry school after college and focus on primary medical care, primary eye care. Ophthalmologists, on the other hand, train for 8 to 10 years after college. They go to medical school, internship, residency, and fellowship. And this is the crux of the issue. This is the heart of what we are discussing here. What is surgical training? What does it take to have the privilege to operate on your eyes? Whether it's a scalpel or a laser, delicate tissue in the eye is being cut and irreversibly changed. That is surgery. HB 349 applies minimum procedures for optometrists to gain surgical procedures. These appear to be mirrored and adopted from the ACGME, the Accredited Council for Graduate Medical Education. These have been erroneously interpreted as competency standards. That is simply not the case. ACGME minimums are for physician training programs. So they're for physicians, the training program itself to keep their accreditation. It's not to imply competence. The training program must, number one, take a trainee that has completed medical school training and internship. Why is that important? Because that trainee has already begun a surgical journey throughout med school. They've been doing IV lines, spinal taps, assisting in C-sections, doing colectomies. They've been practicing surgery before they start their ophthalmology residency. That's fundamental. Number two, the program to develop its accreditation must demonstrate that they have all this volume of complexity on real live patients for their trainees to do under the supervision of a certified ophthalmologist. And it has to be a certified ophthalmologist under ACGME rules. So these minimums that we talk about are not for the individual, they're for the institution. Competency is not assessed by numbers. Take something as simple as driving. Can a driver learn how to drive and call themselves an expert after driving 5 times? Competency in surgery is measured by years and years of training through volume, depth, and breadth of live inpatient training on real tissue, real bleeding. When you have eye surgery, you trust that your surgeon has had adequate training, that your surgeon can react in real time to recognize a complication and treat it appropriately. That ability that you recognize, that you expect from your surgeon, has taken years and years to cultivate, and it doesn't happen overnight. It doesn't happen over a weekend. The optometry school curriculum includes didactic instruction, but live in-person training is not possible. It'd be impossible to do so with 95% of their schools being in states that do not allow laser training. And they graduate 200 students a year. There's not enough surgical patients to train the rest of their students. This is important and fundamental.
Your time has run out. If you want a closing sentence, I'll give it to you.
Thank you. Our two professions work together as a team. We can't do what they do, and they can't do what we do. Our optometrists are excellent at what they do, and we, the ophthalmologists, are excellent at what we do. This is not by chance. It is by training. Thank you for your time.
Thank you. Are there any questions? Thank you very much. Dr. Amy Hennessy.
Hi. Thanks to the committee for allowing me to testify in opposition to HB 349. My name is Dr. Amy Hennessy. I'm an eye surgeon at the Medical Eye Center. We have offices in Manchester, Bedford, Nashua, Peterborough, and now Concord. I specialize in cataract and glaucoma care, and I perform laser eye surgery on a daily basis. I am here today for one reason, and that is patient safety. You may hear that the laser surgeries included in this bill are simple or non-invasive or low risk. That is not how I would describe them to patients and their families. These procedures involve directing high energy lasers to the inside of the eyeball. If this is a model, here's the inside. And in order to permanently and instantly alter tissue. These are non-urgent elective intraocular surgeries. They involve the inside of the eye and they carry real risks. When we say laser surgery, we're actually talking about 3 different procedures with different targets, different technical demands. Laser capsulotomy affects about 10 to 15% of patients within the first 5 years that they've had cataract surgery. And it's used to restore vision by obliterating tissue that's grown over in back of where their artificial lens has been placed. So it's definitely inside of the eyeball. Selective laser trabeculoplasty, or SLT, treats glaucoma by going into the very delicate drain of the eye for 360 degrees using a special lens. Peripheral iridotomy is also used to prevent dangerous pressure spikes in patients with narrow angles and involves creating a laser opening in the periphery of the iris, which will definitely cause inflammation. Each of these procedures has risks, which you have heard about. I believe it's also important to note that while 14 states have legislated to allow optometrists to do eye surgery, several of those states have now issued warnings about blinding complications that have occurred when inadequate training is employed and when patients are not fully informed of the risks. This also means that 72% of the country still does not allow optometrists to perform eye surgery, and no states in the Northeast have certainly enacted similar expansions. As a glaucoma specialist, I frequently see patients referred to determine whether laser is an appropriate treatment for them. Sometimes they don't actually have glaucoma. Sometimes their disease is far more advanced than initially suspected, and I have to talk to them about a more invasive treatment. Allowing an optometrist to then also have SLT might make them be held on to a little bit longer. And if I am seeing them when they have been incorrectly diagnosed, and now there's been a huge delay in care, this is a major safety issue. If a laser is performed unnecessarily or incorrectly, there's an avoidable risk we've exposed our patients to and potentially dangerous delays in the proper care. Precision is critical. If a laser is placed 1 millimeter away from their target, either in the cornea or into the lens or into the retina, it will cause immediate and permanent harm to that eye. Learning how to diagnose these conditions, decide when laser is appropriate, and manage the complications requires years of residency and surgical training, not brief courses using eye models or maybe fruit. The central issue with HB 349 is patient safety. It's not about a professional competition. It's about ensuring anyone performing surgery inside the eye has a depth of training necessary not only to perform the procedure, but to recognize problems and manage the complications that will occur. As it's written, HB 349 removes longstanding safeguards that protect patients. Any legislation involving laser eye surgery should include rigorous hands-on training requirements, oversight, and systems for reporting complications so quality and safety can continue to improve.
I'm going to ask you to wrap it up. Thank you very much. Any questions for Dr. Hennessy? Thank you very much. Dr. Tim Peters.
Thank you, Senators. My name is Tim Peters. I'm an ophthalmologist. I run a practice in southern New Hampshire. I'm probably the most uniquely qualified ophthalmologist with regard to access to optometrists. We have 6 who work in our office. We have 1 optometry resident every year, and we have 12 rotating optometry students from different schools across the country. So I'm intimately aware of what's currently happening. I want to talk about House Bill 349. When this was raised almost 2 years ago, access to care in the North Country was the big deal. And 2 of you are from the North Country. I know you know this intimately. So a partnership was launched with North Country Ophthalmology and AVH Hospital. This required approximately $300,000 of commitment so far with equipment, construction, architects, builders, business planning, legal teams, the works. There are 8 physicians currently working there and from 3 different practices. And I have 16 additional physicians committed to the project. This has allowed us to develop with AVH a 3-year succession plan and recruitment plan to continue that this endures in the North Country. The program opened on January 9th. We've seen patients twice, 2 different days already. We have another day on Friday. We've treated patients already for macular degeneration, diabetic eye disease, macular edema. We've got cataract and glaucoma patients coming, and we invite all of you to come and see it for yourself. I'd be happy to meet any of you there. Because of our concern that House Bill 349 lowers the educational standards and lowers the surgical standards from what is currently required to be a surgeon in the state of New Hampshire, the Eye Society chose to partner directly with the North Country Healthcare Alliance to provide high-quality care, ensuring that the people in Berlin and in the North Country receive the same standard of care that they would get if they lived in southern New Hampshire. The response from the patients has been overwhelming. I would be happy to share those responses with you at a later time. They've asked for high-quality ophthalmology care, and they deserve nothing less. No laser surgeries proposed by HB 349 have been performed at AVH because no referrals have come in for them, which is not surprising because these are rare procedures that constitute 2% of Medicare billings in the United States. So the concept that expanding these surgeries would allow for care for the people of the North Country is mathematically improbable. You're talking about usually a one-time in a life event that happens at a frequency of 2%. Currently now, we have 16 providers instead of the 1 optometrist who's in Berlin, providing care that covers 100% of the range. It's significantly different than what this bill would propose. Other specialties can hopefully work collaboratively with AVH, with the New Hampshire Medical Society, and with the North Country Healthcare Alliance to access the $202 million in federal funding that New Hampshire has for rural healthcare expansion. And we think this can serve as a model. And we would be happy to share our experience to help streamline that process for other specialties to duplicate this idea. Passing HB 349 would make New Hampshire the only state in New England that allows non-medical doctors to perform surgery. Therefore, we would have the lowest standards of any state in New England. You can argue whether those standards are good enough or not, but they would be the lowest standards in all of New England. So the fundamental question is, if the quality of care has already been addressed, then is the standard of care proposed by HB 349 what the people of New Hampshire want?
Thank you very much, Doctor. Are there any questions? No, seeing none. Thank you very much.
Thank you.
Bruce, I have you last here, unless there's anyone after you, but you're in between us and lunch.
Thank you, Mr. Chairman. And for your record, my name is Bruce Berkey. I'm with Sheehan Finney Capital Group, and we are representing the New Hampshire Society of Eye Physicians and Surgeons in opposition to House Bill 349. You've heard some excellent substantive testimony this morning on why it would not be beneficial to the people of New Hampshire for this bill to move forward. In addition to that excellent testimony, I'd like to take you on a statutory journey, which I've distributed to you just now. And it shows, demonstrably shows, concerns in current language, current statute, that will leave confusion with respect to statutory authority. First, on the first page, RSA 329(1), which states in part, surgery means any procedure, including but not limited to laser, in which human tissue is cut, shaped, burned, vaporized, or otherwise structurally altered. Though I'm not a physician, that sounds pretty invasive. Further, in House Bill 349, you will not find the word surgery. It's amazing that that word is not in 349 or any optometry, well, not, because it's laser procedures. As you know, we're opposing the bill, but it needs, if it should pass, guardrails are absolutely required. We're not in favor of passage, but if it does. If you look at 329(1) page 2 of my handout, it talks about the responsibility of the medical community in New Hampshire, with the primary responsibility of the board to work with the medical community in New Hampshire protect the public. Their primary responsibility. You won't find any similar statement within the Board of Optometry statutes in 327. Second, the Board of Medicine, which oversees physicians, is much more accountable to the public than the Board of Optometry, especially for purposes of regulating surgery in New Hampshire. The Board of Medicine has 11 members, but only a minority of them are surgeons, so that there's balance on that board. The Board of Optometry has 5 members, 4 of whom are optometrists. And to an earlier question, we don't know whether any of those 4 optometrists have any experience with respect to laser procedures. Now, I understand my time is running low here, but Mr. Chairman, if you look at the statutes relative to optometry, RSA 327, it talks about the practice of optometry means the employment of any methods or means other than surgery. And then further, another section talks about surgery, meaning any procedure in which human tissue is cut, altered, or otherwise infiltrated by mechanical means. This bill is confusing with respect to authority over surgery, types of surgery, who can do surgery. And then when you take all of that in conjunction with the fact that page 1, lines 7 through 9 of the bill, there's no mention of surgery. But these are laser procedures, and our statutes clearly say that laser is surgery. So given the lack of clarity in these existing laws, I don't know how the optometry board can give clear guidance for qualifying optometrists to perform these surgeries. With that, Mr. Chairman, I'll conclude my remarks.
Thank you very much. Any questions for Bruce? Thank you very much.
Thank you.
That's the end of the list. Is there anyone else that would like to speak on House Bill 349? With that, I'll close the hearing. And we will be adjourning for the day.
you.